As this is our first year, we have decided to make our theme bringing together all the experts who can possibly help strengthen your programs. I would also like to thank all of our sponsors and exhibitors who have also helped make this a successful conference. So please visit their exhibit space booths outside. They have a lot of programs and services to offer you to strengthen your programs. And I would also like to very much recognize my hardworking and dedicated staff who without them we could not have made this day possible. So thank you, all of you. Please just raise your hands wherever you are. And if you see these lovely people here today, I know you met some of them outside. Thank you. This has been somewhat of a great thing because we have identified many, many best practices. We have learned a lot about challenges and lessons. But one of the most important things we've noticed is there are a tremendous number of gaps. And one of the things that we wanted to do as a corporate agreement is to figure out how we can help you fill these gaps so that you can really provide the care for these seniors. And we decided we were going to look at all the experts across the country who are doing this work. And as a result, we have come up with a tremendous group of collaborators that we are planning to work with. And you are going to hear from most of them today. These are collaborator partners from the federal government, the national, state, local levels, and our national corporate agreement partners, those who have been working with underserved populations. So you are going to get an information overload today, but it is all to strengthen your the work that you are doing in your communities. So without that, you're not going to hear too much more from me today, but we would like to just let you know about one change on the agenda. Well, actually, there are two. One of our keynote speakers today, there's a change in her bio, and this is for Administrator Kathy Greenlee. She's now the Administrator for Community Living Services Administration. So we are really, unfortunately, we got the bio after this announcement was made. So we are delighted. I am going to give you a brief update of that. And then the second change is that Dr. Mary Wakefield from HRSA will not be speaking on the first plenary panel session following this one. But we will have Captain Henry Lopez from HRSA update you as well. And then during the plenary sessions, we will take any questions from the audience. So without further ado, I talk no more. It is with great pleasure, and it is my privilege to introduce this morning's distinguished keynote speakers. First, we have Dr. Mary Wakefield, and she is the Administrator for Health Resources and Services Administration as appointed by President Obama in February 2009. So thank you, Dr. Wakefield, for joining us. As well, we have Kathy Greenlee, who is the current administrator for a new federal agency called the Administration for Community Living. Kathy Greenlee is also the Assistant Secretary for Aging at the U.S. Department of Health and Human Services when she was confirmed in June 2009 as well. So without further ado, I'm going to invite Dr. Wakefield to the podium. Thank you.
Thank you very much, Dr. Webb. She's the first person who actually did what I asked at the beginning of a presentation, and that is to cut that introduction really short. There is so much more valuable content that you need to be hearing from your various speakers today than listening to a bio. So thank you, Dr. Webb, for doing that. It's really nice to be here. I also told her that I know pretty much most of you in this room anyway, or you knew me. It was our other guest, my colleague, formerly from the Administration on Aging, and she'll be Kathy will be talking with you about the new alignment of that part of the U.S. Department of Health and Human Services, which is a really exciting new development that those of us who are standing one step removed are very pleased pleased with and are looking forward to working with this new configuration that we think will advance the agenda for people who are, for our senior citizens as well as for those individuals with disabilities across the country in very robust and more effective ways. So as I said, you'll want to be paying attention to that because it's a very new development that is really quite exciting from this administration. I also want to thank each of you for taking the time to be here this morning. This is an extremely important topic. I'm going to devote the few minutes that I have with you, probably about 12 to 15, to tell you a little bit about some of the programs that we have underway at the Health Resources and Services Administration that you might want to know about and that could potentially be useful to you as you advance this agenda, that is improving the care and access for our seniors across the United States. There are resources that you wouldn't necessarily have heard about through your community health centers network, but they are resources that are part and that come from other parts of the Health Resources and Services Administration. So I'm going to give a nod to about 4 or 5 of those in the course of my remarks. I too, though, before I get into that content, want to just acknowledge the HRSA staff that are here, Dr. Henry Lopez and a couple of others. Would those of you who are here from HRSA please stand? I like people to know who they are. Thank you very much. It's a stellar staff with HRSA. Thank you. And if they look unfamiliar to you, please introduce yourselves to them. Make sure that you layer in all of your concerns and problems that you're having, courtesy of the federal government with any one of those 3. They bring them back. In all seriousness, we really are, we take our jobs very seriously with regard to improving performance, both our own and the way we are supporting our grantees. It is a big part of this administration's mission to focus on how we can improve what we do, how we can be more supportive of each of you. So with all seriousness, I am always interested in good constructive feedback about what we can be doing differently to help you be even more effective and efficient. My colleagues feel the very same way, and they are terrific colleagues to work with. So with all seriousness, don't hesitate to contact them. And of course, thank you, Dr. Webb, for bringing this first annual conference into being. I'm sorry this is going to get caught on tape, but I'm going to say it. Forgive me, all of you, for my squinting. I sent one of my contacts right down the sink about 2 days ago. So I'm like this right now. I've got one in, and I think I can read those notes sort of. It's not good under any circumstance. I'm usually using those $12 glasses to boot. So this is a tragedy, actually, probably mostly for you. But please do bear with me. I'm going to be relying pretty heavily on what I think I can see and can't. People don't always think about the Health Resources and Services Administration as having programs that actually do impact the lives of elders in this country. But we do from a few different vantage points. Clearly, the agency that Kathy leads up has a very sharp and crystallized focus in this area. But as I said, we have a number of programs as well that can be resources to you as you advance this agenda. There are programs that range, for example, from our Office of Rural Health Policy, and all of you might know that a higher proportion of elders reside in rural rather than urban parts of America. So for our portfolio of programs that we operate through our Office of Rural Health Policy, that population sector is extremely important to us. You can shift over, and I'll talk more about this in a minute, and look at some of HRSA's workforce training programs that also have a particular drill down, if you will, in the areas of ensuring that we have that we are strengthening our capacity of healthcare providers to provide care to seniors in the nation. Those are just a couple of examples. We've got many others, and as I said, just a few of which I'll be mentioning this morning. And those are programs we've been operating for quite a while. Obviously, our workforce training programs, Office of Rural Health Policy, health centers that serve a percent, relatively small, but a percent of seniors in the country. But now with the enactment of the Affordable Care Act, we have seen a strengthening of many of those very same programs that will allow us to meet even in a more meaningful way the health needs of this aging America. So the backdrop for us at HRSA are a set of programs that touch directly and indirectly the care of seniors in America. But now we've got this new, very exciting tool that we're able to deploy and use that has infused resources and strengthened a number of HRSA's programs and will allow us to do even more on behalf of this population. So while we're going to be, while I'll be mentioning just a few of those items, you'll be hearing a lot more about what we're doing both through this relationship with NAM, but also, as I said, through some of our other programs. Let me just begin, and this is probably one-off for all of you, but I do want to mention it. And that is a campaign that we're kicking off starting tomorrow. That is in the month of May. And this campaign targets seniors. Well, seniors, Kathy, would this be acceptable? Seniors age 50 and older.
Well,
that's okay?
That's what AARP uses.
Thank you. Well, isn't that the truth? I've gotten their mailings. Right, good point. So the campaign that we're kicking off during Older Americans Month, the month of May, is called 50 Plus. And in this program, we're focusing on the importance of older adults becoming organ donors. So you might think, well, why is that important for you in this room? Well, one, because there are a few of you in this room besides me who are over at the age of 50. So you might think about that for yourselves. Yeah, thank you. She's applauding. Good. And also because we're here talking about the elder population that your facilities are caring for and will be caring for in the future. And that makes all of you trusted sources of information, if you will, and the providers that work with and for you, trusted sources of information. To the extent that over the next few months and frankly years, you can help us message on this front, we would greatly appreciate it. For example, this month alone, if you think about the month of April, we've got more than 114,000 people on transplant lists waiting for organs in the United States. More than 100 people every week die on that waiting list. That's how important this topic is. What we also have in the United States is a lack of recognition that age doesn't matter so much to be an organ donor. It doesn't matter so much. That's a bit of a myth. And as I said, as people in trusted positions, you could be helping to convey that message either to your staff or to your neighbors and or to even the people that you're serving. So at HRSA, we're asking you to help us get the word out. You might not know this, but the oldest person that has donated an organ that was transplanted into another individual just within the last couple of years, 92 years old. 92 years old. Think about that. A 92-year-old or a 70-year-old can be a better organ donor in some respects than a 50-year-old or a 45-year-old. It all depends on their health. All depends on their health. And we've got lots and lots of healthy seniors walking around this country. Some of them a lot healthier than some 35-year-olds and 45-year-olds and so on. So please be watching for that campaign. We've got information about it at organdonor.gov, organ donor all one word, organdonor.gov, and help us if you would get that word out. And maybe in a way that ought to be a reframe on that phrase you sometimes hear, 70's the new 50, for example. Well, maybe we should be applying that concept to organ donation. 70 certainly is the new 50. Well, for elder care, shifting off of that and thinking about elder care in this age of the Affordable Care Act, how far have we come? Think back just about 4 years ago to an Institute of Medicine report that was released. It was entitled Retooling for an Aging America. So that was a report released by IOM specifically targeting projected needs to better manage this baby boomer generation that was going to be retiring relatively quickly and coming into the healthcare delivery systems in much more substantive ways. In that IOM report, there were a few strong warnings that were flagged. They identified in that report 3 shortfalls that we were likely to face as the number of Americans over the age 65 nearly doubles by 2030. And these are 3 of the shortcomings that they identified. And the reason why I'm mentioning them is because you'll hear me talk a little bit about some of the strategies we have underway at HRSA that, again, you should be aware of and that are designed to help address some of those shortcomings. At that time, 4 years ago, the IOM predicted first that the current healthcare workforce would not be able to serve the nation's 70-plus million baby boomers, as only about half of that population cohort had arrived in the healthcare system as senior citizens, and there are already, of course, signs of strain. So think about that. First shot across the bow, that the current workforce would be unable to meet the strain of the healthcare needs that would be presented by this population. So now you can start to see where you fit in. Now you can start to see where this infrastructure of safety net providers, community health centers, can and do play such an incredibly important role going forward, and how we are looking to partner with you to strengthen your capacity in this area. The second area that the IOM projected as problematic, severe shortages of geriatric specialists and other providers with geriatric skills. So not just the infrastructure, but also the providers with the unique knowledge and skill set to better meet the needs of this population. And third, an increased demand for chronic care managers as this generation of seniors lives longer, more independent lives than previous generations have lived. And very important to note that over 75% of this senior citizen cohort has and will have at least one chronic condition. Chronic illness is densely concentrated among elderly. And among those over that age of 65, at least 70, among those with at least one chronic condition in the senior citizen population, 23% of that set of individuals have 5 or more chronic conditions. So you start to see the needs that are presented by individuals that are walking through your doors and that will be walking through your doors 6 months from now and 6 years from now. A significant population, and one that has a built-in, if you will, a set of healthcare challenges, oftentimes seeing multiple healthcare providers, making that coordination, that care coordination that health centers are known for, even more important. But also, if not ready for it, really bringing with it the potential to strain your infrastructure as well. And so what are some of the ways that we're working in this area? First of all, of course, none of us would be here today without the Health Center National Cooperative Agreement that is sponsoring the Health and Aging Project, and that's overseen by North American Management and Dr. Webb. This is effectively the kickoff for this project for HRSA. So no surprise, you can expect to be hearing much more about it, obviously later today and in the course of this meeting and in months ahead. This project is designed to provide geriatrics training and technical assistance to HRSA's health center grantees and to other safety net providers. That information is going to be provided remotely. It's going to be provided via one-on-one consultations and through peer monitoring and national technical assistance sessions nationwide. Again, all in the service of building a platform to support your work as you advance this agenda for ensuring access to high-quality primary care and connectivity for senior citizens. The training will also cover areas specific to seniors, areas such as pneumonia, fall prevention, ranging to Alzheimer's disease, to HIV and AIDS care in our seniors population. And on that last front, you might be surprised by this statistic. About half of all people living with HIV and AIDS will be 50 or older within the next 2 years. 50 or older within the next 2 years. I'm old enough to remember when people didn't survive with this disease. And now the wonderful news is it has become, by and large, a chronic condition. But it does mean that this population is aging out, this cohort is aging out, and is in need of continuous HIV/AIDS medications and care protocols. So even if this has been a small set of the population that some of you have served historically, not so in the future in terms of the senior the proportion of individuals that you're serving that will fall into that senior citizen category. Given HRSA's oversight of the Ryan White program, we've been directly involved in ensuring access to care for individuals living with HIV and AIDS. But believe you me, we're paying close attention not just to care for seniors in health centers, but also to care for seniors in our Ryan White clinics because of this great good news. But individuals that are typically presenting not just with HIV and AIDS as senior citizens, but also presenting with comorbidities as well. Some of our Ryan White grantees have already started to form partnerships with senior centers in their local communities. And these grantees are developing their own committee around aging and HIV and AIDS. So they're seeing this coming their direction just as it's coming yours too. These efforts obviously can serve as potential sources for you to develop strategies to address HIV/AIDS care among older adults in the future, even within your facilities. So in other words, we can help connect you to those resources as well as your providers are serving those particular healthcare needs. The cooperative agreement will also focus on addressing issues that may impede seniors in rural communities, including migrant farm workers, may impede migrant farm workers and others from accessing services that can help them remain healthy as they age out and economically secure. So likewise, this cooperative agreement is focusing technical assistance not just on migrant communities and the aged within those communities, but also aging within the LGBT community and in multi-ethnic communities and elsewhere. So you see that this is a very broad portfolio of focus, each of which should have direct relevance to informing your work as we go forward. They have already conducted on-site trainings that target discrete health center populations. Those have been done in California, New York, and Michigan. So we're already beginning to move this expertise on geriatrics to our community health center grantees. And again, we'll be pushing that out much more broadly. For more information on this project, I'll be talking more about it. It's healthandaging.org. And I'd certainly urge all of you to share that resource with your colleagues back in your facilities. And just as an aside, North American Management does have a long history as a grantee to HRSA's Bureau of Primary Health Care, and they're a good resource for us. Henry Lopez is also, as one of our HRSA staff, our local physician and resident expert, is also an important resource for you as you go forward too. Well, thinking more specifically to community health centers, obviously you are well known for delivering comprehensive, high-quality, cost-effective primary care, regardless of patients' ability to pay, and increasingly regardless of the age that they walk through, the age when they are walking through your front doors. You think about the set of services that community health centers offer, and it's hard for me to envision a population that is in greater need of that comprehensive set of services than our senior citizens. So the fact that you deal in physical health care services, behavioral mental health care services, and oral health care services. I can't envision a population or subset of the population that can benefit more from that one-stop shop, if you will, and from wonderful, well-established referral relationships to meet those extra needs that an individual cohort presents with. So your health infrastructure becomes critically important to this set of patients. Of your patient base, in 2010, about 1 out of 5 were age 50 or over. And that, in 2010, was an increase of over 700,000 patients from 2008. So you see that baby boomer generation that's moving into the healthcare delivery system? You're not standing on the outside of it. You are right in the crosshairs of that, too, in terms of providing care. And so quite clearly, our health centers are already beginning to feel that pressure of increasing numbers of elderly. And of course, for virtually all of our health centers, that pressure will continue to grow as health centers become even more central to primary care, to the delivery of primary care services. And of the roughly 19.5 million people that you served as community health centers in 2010, about 1.3 million of those individuals were over the age of 65. Not insignificant numbers, now numbering well over 1 million people. And again, those numbers are going to continue to tick upwards in terms of the care that you're providing. So this becomes incredibly important for us and for you to be thinking about efforts in prevention aimed at that population, as well as the critical importance of interdisciplinary care, doing everything we can to keep people out of hospitals and avoiding all of the billions of dollars of costs associated with preventable hospitalizations, again, especially for this population that typically presents with multiple chronic illnesses. Part of the answer then is clearly access to primary care services, clearly access to primary care services for senior citizens. And as I said, I think we would be hard-pressed to find a more ideal locus for healthcare for this population, given the comprehensive set of services that you provide, as well as the interdisciplinary care that can be found in your facilities. Interdisciplinary care, by the way, is one of the key areas of focus of the Affordable Care Act that HRSA is responsible for deploying. So among other efforts underway at HRSA, we've got a sharp focus on interdisciplinary team approaches to care. That pivots off in some ways some of what you're already doing, but it's really designed to strengthen interdisciplinary this plenary care within your infrastructure and in other parts of the healthcare delivery system as well. Let me share just one example with you. We have engaged with SAMHSA now and have stood up something called the Center for Integrated Health Solutions. It's operated jointly by SAMHSA and by HRSA. It's a national TA and resource center that promotes the development of integrated primary care. That's where you've always come in. And integrating that with mental health and substance abuse care to better address the needs of individuals that present with those conditions, including a focus on older adults. So this is a resource for you as you think about the health needs of seniors that are coming through your doors with both primary care and behavioral mental health needs and substance abuse needs. So this center provides training and technical assistance specifically to 64 community behavioral health organizations. And this month alone, that center is hosting 7 webinars and delivering about 17 conference presentations, all of which are available on their website. It's available to you and to the providers in your facilities, and it's state-of-the-art, cutting-edge information. If you're interested in accessing it on the web and looking at either webinars that have been conducted or signing up or having your provider sign up for those that are coming down the pike, you can go to integration.samhsa.gov, SAMHSA, S-A-M-H-S-A, and that's available for viewing anytime. That grant program is part of really an unprecedented push to help prevent and reduce chronic illness and to promote wellness and treat behavioral health needs on an equal footing with health conditions, something that all of you would be well aware of. Some of the rest are just starting to understand. I also wanted to mention, as it would be known to some of you, President Obama's announcement of a 3-year demonstration project in 2009. That's the Advanced Primary Care Practice Demonstration to support centers in serving as integrated health homes for Medicare beneficiaries. It's probably known to all of you, that investment of resources. It's one of the first projects it's the CMS Innovation Center announced. That was being formed under the Affordable Care Act and specifically targeting Medicare beneficiaries and community health centers. And as you might know, under this demo, we've got 500 participating health centers that are transforming into advanced primary care practices. But again, you see the Affordable Care Act really leveraging assets and trying to strengthen that health center infrastructure to meet the needs of seniors in health centers across the country. Finally, a couple of comments. We're also very involved in a focus on training. A key aspect of primary care for the aged is ensuring that they have access to healthcare providers that understand the diseases that they are facing. And that's why you've seen an unprecedented commitment by this administration specifically to the care of individuals with Alzheimer's. Secretary Sebelius has felt very strongly about ensuring that we're leveraging our assets in this area, and as part of that agenda, we're doing the same through our resources as well. So to give you just one example, at HRSA, we've directed $6 million into our 45 geriatric education centers for the development specifically of Alzheimer's training curriculum. Those training curricula will be developed over the next year or two, and as that moves forward, we'll be pushing that information out broadly to all of you and to your other health center partners. As a result, you're going to see that information made available, as I said, to each of you, and you're also seeing additional resources coming into our geriatric training centers, which we operate through our Bureau of Health Professions. We, for example, last year alone touched about 64,000 students, faculty, healthcare providers with a very sharp focus on geriatric health. And boy, do we know we need to be doing more of that. So we're there. Those are some of the same providers who are going to be working for you as we go forward. It's just crucial that we've got providers that are competent and qualified to provide care to this population. Likewise, the National Health Service Corps, known to all of you, about half of our core providers functioning and practicing in community health centers. We've got targeted curriculum that's specifically focused on care of the aged, nutrition and aging, for example, that's being delivered directly to our current National Health Service Corps providers and also to National Health Service Corps alums. So you start to see how we're threading these resources through on the provider side as well as to you on the delivery system side of the equation as well. So that gives you just a sense about the footprint that we're starting to develop in the care of our aging population. As we move this agenda forward in tandem with all of you, we need to be told by you and informed by you what are the resources you need to make an even stronger infrastructure, to develop an even stronger infrastructure and provide a key source of care for our elders who seek it, and also to ensure that we're leveraging all of HRSA's assets every possible way that we can. So on that front, I'll end where I started, and that is to say that we invite your input. We need to hear about your concerns to make sure that we are all working in partnership as cohesively as we possibly can to provide care for this incredibly important sector of our population. Thanks so much for the opportunity to be with you this morning, but a special thanks to each of you for the extremely important work that all of you do. We are very privileged to be your partners, and I'm so thankful that you're here taking up this cause with us as we move this agenda forward. Thanks so much.
Good morning, everyone. Well, I'm going to stick around and be on the panel, so I'm going to keep my remarks kind of brief so we can bring the rest of the panelists up here. It's wonderful to be here this morning with Mary. Administrator Wakefield and I don't often get to do events together, so shout out to Mary. It's nice to be here with you. Perhaps because of this work, we'll have more opportunities, so I look forward to it. Like Mary, I have some staff in the audience. Rick Nichols is here, Danielle Nelson. They're both doing workshops, I think. Rick, are you doing a workshop too? Danielle's doing a workshop. Rick's going to go to the workshops and ask hard questions. Alex Rossetti, my assistant, and I know there are several members of the Aging Network. I can see you all around this morning, so welcome to you. I want to give you just kind of a basic framework or frame of reference for my work and how I see the transformations that are occurring right now, and then I can give you more detail as we work in the panel. 2 years ago this time, so April 2 years ago, I was mostly moping around. The health reform bill passed in March, and I felt like we were left out. Administration on Aging got $10 million a year for 5 years. HRSA got a lot of money. I mean, we didn't get any. I mean, we got $10 million a year for 5 years for Aging and Disability Resource Centers. So I moped around for a couple of months, and I've gone from moping around to now, 2 years later, thinking, oh my goodness, this is huge. So I just want to describe that transformation. I realize that the way I look at health reform is very different, and Secretary Sebelius has heard this riff as well, because I've said this is how I see it. But I believe the health reform bill, the Affordable Care Act, was about two major issues. One was about insurance market reform. That's not my stuff. I mean, I can follow it. I have an insurance background, but much of the Affordable Care Act was about insurance market reform. The other major piece was about the healthcare system reform. And that, I think, if you look at both the resources and the focus of the Affordable Care Act, was largely about major hospital systems, big medical providers, hospitals and doctors. And that's really not me either. But I have become convinced over the last 2 years that we, and you're in this soup with me, we, the community providers, are actually the finish line for their work. That the transformation of the medical system in this country will not be successful without the community partners. Because the goal of that transformation, if you think of, and this is how I visualize it, if you think of the medical system, the healthcare system, this is how you look at it. Wow, it's huge. If they look to downsize or shift their cost curve or provide a different kind of service, they will look to us as community providers. That they will need us to offset cost and care, and we must develop quality in order to sustain this shift. So we have huge medical systems in this country looking for new partners, and they are looking for community providers. They're looking to the Aging Services Network. They'll be looking to community health clinics. They'll be looking to our partners in the field of disability. They'll be looking to the public health system. They will need all of us. No single community network in this country is large enough to handshake with the medical system. We simply do not match their size. But this is a transformative opportunity right now to partner. We spent we continue to do this, but certainly our initial focus after I got over moping was to start looking at opportunities coming out of the Innovation Center at CMS on how we could participate in the community care transition, the hospital transitions work, how we could bring hospital providers and aging service networks providers to the table. This continues to happen. This continues to be very successful, but we need more. I do a lot of speaking, and Sandy and Martha are going to be here on the panel with me. I speak at their conferences every year. And I spent the first couple of years talking about what I call flirting with CMS, where we're spending a lot of time looking at CMS and their funding and figuring out how we can play. How can we participate and contract and get ourselves to the table? The other half of this work looks like this to me, which is, okay, team in the community, we got to do better. I mean, we have to be able to provide more resources, we have to be able to provide a different kind of outcome, and we have to learn who each other is. It's early. We have to meet each other. And so it was about a year ago, after we spent kind of the first year looking at the opportunities with the network, that I realized that I needed to take a better look at what HRSA provides. And Mary and I started talking. This was about the time you signed your contract to look at what you can do with seniors, because I see these same numbers, and I've heard you give these numbers about the increased numbers of seniors that are coming to federally qualified health clinics, FQHC lookalikes. We also began an increased conversation with the Centers for Disease Control so that we can figure out in the public health world how we can provide additional support and leverage. I think it will take all of us working together to build community systems and to be able to find a way to provide good quality care at less costs in the community. And we must find ways to work together. Last August, you have a national association, I've forgotten what it's called, the FQHC National Association. I asked one of my staff members to come to the Aging Subcommittee at your convention, it was in Southern California last year, so that we could start trying to figure out if the area agencies around the country are working with the FQHCs. That's why Sandy's here. Are we working together? We need to partner at the local level in every way that we can. But we must also partner at the state level and make sure that we're working with the state health departments and with the rural health agencies that you have in the states. How can we make sure that we're integrated together? This is our ongoing work. How do we all come together? And new things will be required of us. What is particularly troubling, back to me moping around 2 years ago, is that the budget, the Administration on Aging budget, has not been growing, and really has not grown since it was passed 45 years ago. That the AOA resources are fairly flat. So we must figure out how to help you spend your money, because ours isn't growing. We must go to the other partners that we have and help them spend their money, meaning all of us together need to look at the book of business with regard to seniors and figure out how we can support each other. So Mary and Asriel were describing my two worlds and my dual roles, which now I think I have provided some context for. There is huge transformation going on. The Affordable Care Act is one engine. The other engine would be happening at the state level with Medicaid transformation, where many, many states are moving to a managed care system for their long-term supports and services, and that also is providing a great kind of catalytic event for community service providers. If we are going to work together sufficiently, we must reach out and work with new partners. And I have felt very strongly for a long time, before even coming to Washington, that we had huge collaborative opportunities to work between the fields of aging and disability. What we announced 2 weeks ago, which is why the information is outdated, it's just 2 weeks ago, is that we formed a new operating division. That's HHS lingo for a standalone agency within HHS, the Administration for Community Living. And what we have done is we've pulled together the Administration on Aging, which will continue to exist, the Administration for Developmental Disabilities, which has existed over at the Administration for Children and Families, and the Office on Disability, which is a function of the Office of the Secretary. We've taken these three entities that all have their unique identities, and we've built a new house on top of us, a new umbrella structure, and called it the Administration for Community Living. And we chose that name very intentionally, that it is the common mission of all of us. It is also the common aspiration of the people that we serve, that all people, regardless of age, from children to seniors, desire to live in their communities for as long as possible. The Administration on Aging will continue to exist. It won't be the operating division. It will be a program under the Administration for Community Living. I will carry two titles, the Administrator, the Administration for Community Living, because I wanted to be like Mary and be an administrator. But I also am the Assistant Secretary for Aging, and I'm very proud to be the Assistant Secretary for Aging. The Aging Network worked very hard, and 2 decades ago was able to elevate this position to a Senate-confirmed Assistant Secretary level, and that's embodied in the Older Americans Act. So I am very proud to be that Assistant Secretary. By doing this reorganization, we've opened a large question with all of the community providers, all of our community partners, both aging and disability. My goal is that we can go through a public conversation about the Assistant Secretary role and figure out whether or not it's possible to lift it, to make the administrator basically the Assistant Secretary. That the head of this administration on for community living should be the Assistant Secretary. But it's a statutory creature, and so we need to be able to have this conversation with members of Congress as well. So for now, I will have both titles. We'll use both titles. I'm proud of both. But we have wonderful new opportunities to work with the field of disability, people with disabilities, and their multiple interests. None of this that we're doing is in any sense a desire to indicate in any way that these fields are all the same. That we are trying to do something quite novel in this new administration for community living, which is reflect the unique identities from the different fields in disability and aging and the common denominators. And Mary mentioned many of those, from workforce, I mean, there's transportation, housing, community services. These are the common denominators. But each of these areas, aging and disability, have very proud, unique constituents, unique histories, and this new agency must reflect those as well. So we will try to find a balance between what we have in common and what's unique, because not all people are the same, but they all want to live in the community. So let me stop for now. I will give you a little bit more as we work on the panel together, but I'm so glad you're all here this morning as we talk more together. Thank you.
Well, I hope you are as inspired as I am right now by both of our administrators. Dr. Wakefield, thank you so much for coming. And Administrator Kathy Greenlee, thank you again for your remarks. We would like to invite our first plenary panelists to come forward. And as they do so, we're just going to briefly have their mic. And I'm going to invite Sue Lackerman from the National Council on Aging, who will be our moderator for this particular panel. Thank you.
It's delightful to be here, and I'm truly honored to introduce this panel. And I'm going to take a lead from our previous speakers and ask you please to look and read the bios. I know we're a little behind time, so I'm going to go ahead and get us started right away. My name is Sue Lockenmeyer. I am the director of the Resource Center at the Center for Healthy Aging, the National Council on Aging. For those of you who might not be familiar with us, our mission is to improve the lives of millions of older adults, especially those who are vulnerable or disadvantaged. So I think I'm speaking to folks who really have much of the same mission. I'm thrilled to be here. I wanted to just quickly give you a couple of examples. I know that Dr. Wakefield gave some examples of some things that are happening, and I wanted to share some of those new partnerships between aging community and the community health centers. One in particular is Oregon, who is working with the Primary Care Association to implement the Community Health Center Patient Self-Management Collaborative. And several of their FQHCs are actually providing the systems, the training, and the staffing necessary to integrate referrals to community-based self-management programs into their regular visits with their clients who have chronic conditions. And then they have community ambassadors who are really working with them to transition those individuals and to get them into these evidence-based programs. In Colorado, the Consortium of Older Adult Wellness is, again, working with their QHCs and their patient-centered medical homes to embed access to community-delivered chronic disease self-management programs. And with the grantees that we work with, again, under Assistant Deputy Kathy Greenlee, we have 46 states, the state units on aging and the Aging Network, who have been working really diligently with a lot of you. So I think this work will continue. We're really excited about it. And with that, I'm going to go ahead and ask our panel. We'll hear first again from Kathy Greenlee and then from Henry Lopez. if that's all right, and then we'll go to Martha Rorty and then to Sandy Markwood.
I feel like I should say I'm back. Okay, let me give you a little bit more. Then really, I want to hear from the panelists. I talk about 1965 a lot, and I don't know if you all have heard me talk about 1965 because you're a little bit different audience. So let me do that very quickly. 1965 was a big year for seniors because there were 3 laws that were passed in 1965 that have a tremendous impact on their lives and their health. You know about these laws, but I need to describe them to you a little bit differently. One, of course, was Medicare. Medicare becoming the primary payer source for acute care and hospital services, doctor services for seniors. Medicare is an entitlement. Entitlement means 2 things. It means that when you're eligible for Medicare, you get everything that you're entitled to under the Medicare program. Now, there are usually rules about the procedures and codes and so forth, but once you're eligible for Medicare, you get what Medicare offers. And this is a tremendous benefit for seniors. The other thing that entitlement means, from a federal budget perspective, is it's a mandatory program. It's paid for on a mandatory side of the federal budget. So entitlement has 2 very significant but slightly different meanings. The second program that was passed in '65 was Medicaid. Medicaid has become the single greatest payer for long-term services for seniors in this country. Medicaid is also an entitlement, different than Medicare in that it's a federal-state partnership. Once you're eligible for Medicaid, you get both things. You get everything that the medical card will buy you under Medicaid, and it's also an entitlement, meaning both the federal and state governments must pay for the Medicaid services. One of the misconceptions, I believe, about Medicaid with older adults is that it's not necessarily for the poor. And I think this surprises people. That what we have built in this country are long-term services that are so expensive that middle class and lower middle class individuals can't afford them. In the Medicaid world, these people are called medically needy, and that's what it means. It means that they're upside down in their finances. This is why you hear about seniors needing to spend down their assets. In most states, in Kansas, it was $2,000 in assets, meaning that there were assets to spend. Even after seniors have spent their assets, most seniors have some sort of monthly income, Social Security, retirement, some of their own investment incomes. But what we find for many, many people, thousands of seniors on Medicaid, is that their monthly expenses in a nursing home exceed their monthly income. And it's important that you know that this is how this works, because if we start looking at how else we could pay for services, you need to understand that there are many seniors who have resources, and we need to build systems they can afford, rather than expecting them to pay for services that are out of their reach. 60% of all seniors, when they enter the nursing home, are paying for their own care. And many of those spend down because nursing home is so expensive. Of course, there are seniors that are poor, who have always been poor, who age into being poor, and we should not overlook them. But you should not assume that for Medicaid and seniors, everyone is poor. There are resources in the system. When I was in Kansas and paid the nursing home bills, I knew that 18% of the entire cost was paid for by seniors themselves, which means there's some money there we could use. So Medicaid was passed in 1965. The Older Americans Act was passed in 1965 as well. And I always tell people, if you look back to 1935, reaching back to Social Security, which was about poverty protection, basic income, Medicare for acute care services, Medicaid for long-term services, the piece that was missing was the piece that the Older Americans Act was designed for and still serves, which is preventative services. How can we provide services to individuals to help them age in place and stay out of the hospital, stay out of the nursing home, and stay in their community and stay healthy? It's most significant that you understand that the Older Americans Act is not an entitlement. It doesn't meet either of those 2 tests. Someone who turns 60 is eligible for the Older Americans Act. They're not entitled to it. We will come through our network, we will come to someone's home, we will do an assessment and figure out what are the functional impairments, what do they need, and deliver just what's needed. And if the impairments become more significant, which is often the case, then we'll provide more services. In this regard, it's more cost effective because we're providing community services on an as-needed basis. It also is not an entitlement in the federal budget. It's not paid for in a mandatory way. It is a discretionary program. And it's important that you know that because the Medicare and Medicaid budgets have ballooned mushroomed, every big word you can think of since 65. But the Older Americans Act has not grown. And this is a challenge for us as we see the aging demographic and the need to serve more seniors. I believe the mistake that was made in 65 was not figuring out what we should do in terms of investing in a relative way, a little bit of support for community services, some support for long-term services, and some support for healthcare services, that we never figured out for an individual how we should divide the cost. I can tell you that the community services are woefully underfunded, but I don't know by how much, because it's not been possible to measure that issue. How could we figure out what the pie should be? And in that pie, Older Americans Act should get services, you should get some services, the mental health system should get some resources. How do we quantify the pie? Much of the opportunity that we've been chasing since the Affordable Care Act was passed has been about this integration between the community services and the health services like I talked about. I see this integration coming up in 3 different ways. And when you listen to conversations, I just want to give you these 3 so you'll hear my voice saying this is what I'm talking about. Accountable care organizations are a way to repackage and rebundle and figure out how do we pay for services to keep a community or population healthy. Medical homes. I tell people that the happiest people about medical homes are geriatricians because they've been medical homes for their seniors for a long time, providing a whole array of services and seeing both the patient but their family, as well as the care transitions that that I did mention, where we're working to integrate hospitals and community services providers. These 3 new opportunities are an opportunity to go back and revisit how should we stitch our services together and how should we invest in them. As we do this work, one of the issues that has become the most significant for us is how we measure quality. That the answer to whatever the questions are about saving costs is not to medicalize everything in the community, but to find community partners who can deliver services in an evidence-based way that produce good quality. We need clinical measures in community services, and we need quality measures that are otherwise, like quality of life measures in the community. How do you measure against isolation? How do you make sure someone is integrated and has access to what they need? These are some of the most innovative and interesting questions of our time. How do we build different kind of community services? The other mistake that was made, I think, in 1965 is falsely thinking that social services were just fluffy, that social services shouldn't be based necessarily in science. We began over a decade ago with the Administration on Aging, working specifically on evidence-based programming to demonstrate fidelity in our work, to develop outcomes in our work, and show that we can improve health and save lives and save costs by investing in community services. What I have been doing most recently is asking our network of aging services providers to reach out to you, to contact you at the state level, contact you at the local level, and start talking about how we can amplify our services together. There are some parts of the country where we can't find oral health services unless they're provided by you. There are places where we can provide chronic disease self-management in a setting that's not the federally qualified health clinic, but will help the patients that you serve. So my greatest goal in what you're doing here at this conference and in the workshops is that you find new ways to partner at the state and local level so that we can integrate these community services. And since you are health clinics, we believe you are in a good position to help us translate, because there are times when we come to the table with the big traditional hospital systems that we need someone to help describe what community services are. And you are a nice intermediary for us to these more traditional and large systems, and we need your help. So let's go talk to the panel. Thank you all.
All right, good morning. You know, first of all, I want to congratulate Assistant Secretary Gringley on her promotion level, because it's important. You know, this is the future as we continue to age, as we continue to get better looking and more handsome. People tell me now that I'm all gray that, oh no, it looks great on you. You know, and I think I heard the president the other night on the in the dinner that they had with the press. I forgot what they call that. Correspondence dinner. He said he's gone from number 1 to number 5 now in the Just for Men as he's aging, you know, so I don't want to do that because it'll conflict with my black uniform here, but I'm going to walk around, for those who know me. One of the, oops, where's my, Anyway, I know I got a few minutes, but I'm going to say this. What you've heard this morning from Dr. Wakefield, our administrator for HRSA, where I'm under the Bureau of Primary Health Care in the Office of Special Populations, and you heard from Assistant Secretary Greenlee this morning, and I've said it, and we've said it. Oh, wait, just a minute. See, last year I said my right side, my mom. The other day, and Jay Leno said somebody took a study, a government study, said that the left side is the best side. So, yeah. So thank you again, Mr. Photographer. No, all kidding aside, it's important that we partner together. I cannot overemphasize that. I'm a firm believer. If we don't succeed and work together with other departments within our own Department of Health and Human Services, and then our other sister departments as HUD, Education, USDA, all these other ones, EPA. And if we don't do this, we can't succeed to provide the services as we continue. Things are changing, folks. We are living longer. You know, I keep an eye on my father, who's going to be 85, God willing, in July. My grandmother was 99. So I'm hoping that I have those good genes. But life's changing. You're talking to a man who rides in his car for an hour and a half to 2 hours one-way commute, gets to the building and sits all day, and then commutes another hour and a half to 2 hours, then home. Trust me. Do I want to exercise when I get home? Sometimes, but most of the time I don't. I use the excuse I walk around a lot. To include all the stressors of the day, to include you get home in the computer and you look at your BlackBerry, you look at the computer, you're constantly working. That's stress. So I promote this, a balance of work and life. Don't forget to keep the balance. You got to take care of yourself so you can, be taken care of as you get older. I want to do a quick presentation here, national overview of health center programs, the Office of Special Populations, the role we have in addressing the health care for seniors, elderly health, and HRSA national cooperative agreements. Dr. Wakefield mentioned we see 19.5 million patients a year. That's over 77 million visits. As I visit some of the health centers and I go through the waiting rooms, I have started to notice that there are a lot of senior citizens. When I first came to this program, and they said I was 4 years ago, and it's been 4 years, unbelievable, I started to notice the senior citizens in the waiting rooms has grown. I didn't pay attention to that until I started to take my dad to the doctor's office when I'm with him in San Antonio, Texas. And all of a sudden I said, oh my God, we're getting older. Then I looked in the mirror and said, I'm getting older. If they're getting older, I'm getting older. And it's important. And one of the things I ask myself is, one of the questions, I don't know if you do it, in the mornings, it's springtime, you hear all these birds. I have a lot of trees in my backyard. And then you say, where do these birds go? How long do they live? Where do they go die? Because you never see them, well, in some states you do drop out of the sky. But, you don't know where they go. And I mean, so all of a sudden people say, where do the seasonal farm workers go? It's a hard life, it's hard work. Where do they retire? Where do they get their medical care? So we have migrant health centers to provide that care. So I'm trying to focus to ensure that our health centers, through working with North American management and providing technical assistance, to make sure that they address the special concerns of this particular segment of the population, which is a special population. We have over 8,000 sites. We have 1,100 grantees. All that means is some of our grantees have satellite sites and areas, because we come to your area. If there's a need to be in your area, we're going to be in that area. Am I yelling? Am I yelling? No, okay. Because I don't feel the echo. But it's important. Here's the important thing. Do I have a laser or no? Yes. Do I? Yeah. Yeah, there it is. Over 131,000 staff. I'm emphasizing that because we have a task to ensure that all these staff members don't ignore the special concerns of our aging population. When you ask them a question, such, are you taking your medication? How many medications do you take? Who did you see last time? Because if they gave you the meds, that you stopped when you saw a different doctor? Because sometimes they just keep taking them until somebody says, oh, don't take those anymore. Trust me, when he said, bring your medications, I bring you 6 or 8, maybe 10 prescriptions or 12. And they said, why are you taking this? Well, they never told me to stop it. They just kept giving me different ones. And it happens because they follow the word of the physician, of the nurse practitioner, of the health professionals. So we have to make sure that we communicate with them correctly. And those are the kinds of things that we have to make our staff sensitive to. And working with you, as you go out there and educate folks, we got to make sure. 50% of our health center patients are 25 to 64. Importantly enough, I think Dr. Wakefield mentioned this, it's growing each year. I'm not going to repeat, y'all can read, but and this is going to be available on the web for North American management, correct? Correct. Okay. So there's just look at the numbers as they increase. 152,000, 80 to 84. It just keeps getting bigger and bigger. This is where we are across the country. Dr. Wakefield mentioned the fact that we're all over. We are, and we're expanding, folks. Thanks to the Affordable Care Act, we're putting out some more money in the next couple of months in an effort to place more health centers and fund hopefully more health centers in areas that are needed. And we show there's an area, rural health areas. We're trying to get out there because we know there's importance in working with them. Now, y'all special populations. Who are we? The Bureau of Primary Health Care funds 15 organizations with our national cooperative agreements. This is an effort. It's a partnership. We can't do it all from the Bureau of Primary Health Care, from HRSA, from HHS. We have to have organizations, associations, professional organizations that can provide technical assistance to the folks that we're outreaching to you guys out there, in an effort to make sure that we provide the right, correct type of services out there. If we don't do that, we're not going to reach our patient base. The ultimate reason we're together here is to make sure that we provide the services that are needed by these folks that come and see us and gain confidence in us and gain the trust in us. In September 2011, the Bureau of Primary Health Care awarded grants to North American Management to assist health center grantees on capacity to serve the aging. They also provided to remote on-site and one-on-one TA. We provide, now it's free. This is free service we provide, technical assistance. We want you to succeed in what you're doing and reaching out to these folks. Elderly Health Program, an update right quick. The Health and Aging Cooperative Agreement, it's a collaboration between Administration and Aging, and I had the pleasure of meeting the former assistant, Cindy Padilla, who went back to New Mexico, I believe, who was, I think, Secretary of State in New Mexico at one time or something.
She's the Secretary of Aging.
Secretary of Aging in Mexico. A wonderful person. She approached me, we met, and said, listen, what are you guys doing? I said, we have aging. And so we have to talk because it's important. One of the positive things about this current administration, he says, all of you guys are working in silos. We need to work together. So I've taken advantage of that because we've never done it before. How many times do you try to call a bureaucratic organization and you can't get to the right person because nobody knows who's who? So we're working together. This is why we're here. This is why we're partnering with our colleagues here and trying to make a difference to succeed and provide the services as we work with you. Conduct a needs assessment. We provide individual TA, develop calendar events. Our website, you heard it mentioned this morning. Again, if you don't take the notes now, it's in the website or in some information in your booklet. No cost. It's free. Trust me. It's not like the commercials on late night TV or Saturday. It says, for $19.95, we get one. This is free. We conduct webinars and we put them online so you can see it and utilize, so you can maybe train your staff on that. We conduct to understand the needs of adults age 50 and better. Other NCIs, we have migrant health promotions. We try to capture all the special populations. We have community health partners for sustainability. Programs all-inclusive care for elderly program, PACE. We have the Fenway Institute. That's a new one because we have a special population for the lesbian, gay, bisexual, transgender folks. So in adults, we have others. We have HRSA resources. We have North American, you met Dr. Webb. I know how. What can we do? Talk with your providers, talking with aging population served, participate in trainings, request free technical assistance. This is not a commercial, folks. I want you to understand that these services are available to you in health centers, and to make sure that we are providing the correct type of services so we're all in the same sheet of music, singing from the same song, so we can all harmonize together and sound great and provide those services out there for these folks. Thank you. Now, I know I went fast. People who know me, I talk. I'm available to you. We have today, I want to introduce one person who we did not introduce, but today we have Kevin Bates from my staff. Raise his hand. He is the project officer. We have Dr. Seti Page, who is the current chair for the National Advisory Migrant Council on Health for the Secretary of Health and Human Services. Dr. Page, you want to raise your hand? He is the folks that take testimonies across the country for the migrant population to see what kind of health services they need in an effort for us to provide services. Bottom line is, we have health care for the homeless as well. Okay? We have veterans health. We have the school-based health centers. We have, residents of public housing. We have aging, veterans. I say all this because all these special populations, we learn from them, we hear from them, we hear from the kids. If their kids are getting sick in school, we try to find out what's going on. We try to make sure that the folks know, hey, if they're getting sick, they're acting out, depression, let's find out what's going on. They could be staying with their grandmother, who the grandma's sick or the grandpa's sick, and they may have issues. So we want people to think out of the box. I know we're busy. We got to see 20 patients a day or 50 patients a day, a 48-hour day instead of 24-hour. But that one question could make a lot of difference for some folks and some families. And last but not least, I think you met my staff that was here, but I always do this. My phone number, my cell number is 703-861-0700. Why does he do that? Because you're important to me. And for those who know, don't I call back on Saturdays and Sundays? I know I'm crazy. I don't follow the work-life balance. But the reason is, if it's important enough for you to call me that time, it's important for me to call you back, because that's an issue you have and a concern you have which affects other people. So don't hesitate. 703-861-0700. You have my office number. That's cool. But don't hesitate. And remember, I come in 2 hours a day in the morning and 2 hours in the afternoon. I don't answer it by head. I have the thing and the speaker thing. You can talk to it and all this good stuff. So don't worry about that. I don't want to get a ticket. I'll close with this. It's a partnership between you, us here in the federal staff, for us to make it work so we can provide the services to those who need the services. Thank you so much for your time this morning.
Thanks, Henry. Sure. And while we're getting up the slides, I just want to introduce our next speaker, Martha Rorty, who is the Executive Director of the National Association of the State United for Aging and Disabilities, also a newer title.
Good morning. I'm not as funny, and I'll start like this, right? The photographer's nowhere to be found. I do also have terrible allergies, so I apologize for the frog in my throat. It's not sexy anymore. Last week it was pretty cool, but this week it just sounds like a frog. I want to just explain first who we are. Our association represents the state agencies on aging and disability, and we took on that extra role in 2010. I thought it would be a little bit controversial, but it took 6 minutes from start to finish for the members to vote on it. And the reason is because they'd been serving the aging and disability population for years without us taking that role. So since then, we've been doing both aging and disability services. When we do our annual surveys each year to determine what the members actually do, though, it can kind of be broken down into 4 buckets of services. And I've kind of made these names: inform, protect, serve, care, and prevent. I put care and prevent in the same. I apologize for that. But basically what it is that we run the information and referral lines, the ADRCs, the Aging and Disability Resource Centers, and the SHIP programs. For the protection, we're responsible for the elder abuse work that we do, adult protective services, the ombudsman program, all of the elder rights, including legal assistance. For serving the bulk of the aging network, 40% of the funding goes to serving meals. We run employment programs, transportation, respite, family caregiving, etc. There's many, many things on that list. I think there's over 40 services that 80% of the states do. And then care and prevent. Most of the members also now are running the operating agency for the Medicaid program. And it is the Medicaid waiver that they're administering. And I think there's an important distinction, too. When Kathy was talking about the Medicaid program and the nursing home care, unfortunately, the nursing home care is the entitlement right now. Home care, if somebody wants to receive medical care as a senior in their home, that is still not mandatory. That's a waiver service. And therefore, many people are kind of required in order to get care to go into a nursing facility. So we've been long arguing that the entitlement should be reversed, that people should be able to receive care in their homes and communities and not be forced to go into institutional settings. Most people would prefer that. And guess what? It would save us a lot of money if we did it that way. On average, the United States right now, we pay $60,000 a year for nursing home care. At home, we can do the same level of care for $12,000. So I'm just arguing for that one little thing. I always do it when I have a captive audience. Our funding for state aging and disability programs comes from a number of sources. The first is usually, or is always, a state appropriation. Is the largest source of funding, is the states. The second is the Medicaid program. And way down on the list is AOA. AOA right now is on average making up about 6% of the funding that's coming into state aging and disability programs. So we have to really cobble together the funding that we do in order to run the aging and disability programs. One of the significant trends that we've been experiencing in the last 4 years is the recession has hit the state aging and disability programs particularly hard. As it has affected all of us, it's been particularly hard for the states. As Kathy mentioned, the Medicaid program is a huge portion of the state budgets. When I started in state government, the largest expenditure in states was always K-12 education. And about a dozen years ago, it started to creep up that it was Medicaid, and now in every state, Medicaid is the #1 expenditure. It is an entitlement, and so it can't stop growing. So that means in a recession, everything else has to be cut except that one program. So aging and disability services, except for the clinical side, have all been reduced. Every single one of our states has reported they've taken a cut. We've had states that have reported cuts up to 25% in the last 4 years. That's a little bit on the high, but every state has reported at least 10%. So that's a significant challenge that the states are dealing with. Another challenge that they're dealing with, and Mary Wakefield talked about this earlier nationally, but at the state level we have a real crisis in state aging and disability workforce. One of the ways that the states dealt with the state budget crisis was to offer these wonderful incentives to have people retire, but that left us with a dearth of people that know aging and disability services. We lost about a quarter of the staff. 44 of the state aging and disability directors have changed since January of last year. Not every state, that doesn't mean that 44 states have new aging and disability directors. What it means is in some states we had 2 or 3. But I think in total we had 36 states that have new directors in the last year. So we have both at the top level and at the mid-level, we have a real crisis of people that have experience in aging and disability services. Many of the states continue to restructure their programs, and as I had indicated, a lot of them were already doing disability services, but they're doing even more disability. In the beginning, states were doing programs related to physical disabilities, and now we're even seeing them working on disabilities of all sorts, including developmental disabilities. And frequently we hear from our members now that they're really doing the long-term services and supports regardless of age. One of the members a couple weeks ago quipped that she had the youngest client that she was working with was 5 months old, and her oldest at that point was 105, and she thought that was really quite fun. Quite a challenge for sure. States are also looking at their local area agencies on aging, and Sandy knows this, to really see if they're running the most efficiently as possible and if they have the right number of them. Always in a time of change, that's one of the things that states are going to be doing. But it's not just the area agencies, it's all sorts of their providers and seeing if there's better and more efficient ways of doing it. Kathy also mentioned the Medicaid managed long-term care is coming to a state near you. So far we have 28 of the states have moved into delivering their services or are in the process of or already are delivering services through managed care. Managed care isn't new. The state Medicaid program, 70% of Medicaid recipients are already in managed care, but they have not done the managed care for long-term care populations. And so this moving the more complex cases into managed care is a relatively new trend. And it is concerning in that a lot of the way that we've been paying for community services has been using the Medicaid program. And if the managed care companies don't contract with the local providers, that could even further shrink the budgets that we have. So we're working really hard with a lot of the managed care companies to explain how wonderful the Aging and Disability Network is and how many things that the Aging and Disability Network can provide for them. But it is a time of real change. State legislatures, in an effort to really control the state budgets, are moving at rapid speed into this new area of managed care because they do believe that it will save money in the long run. But if we don't educate them right now, we could face a further crisis. I think that just one last challenge that we're facing is really the Affordable Care Act and getting our message out about long-term services and supports. Many of the Medicaid directors and state health directors and officials are so caught up in how many things they have to implement by 2014 that long-term services and supports is kind of the afterthought. So it's really the role of the Aging and Disability directors, I think, to get the message out and to take care and take the mantle up for the Affordable Care Act portion that is long-term services and supports. Because otherwise it's just too big of a challenge. There are so many things that have to be implemented in that arena. So with that, I'm going to turn it over to my local partner, I think, Sandy. Oh, I didn't even give you a chance to introduce her. Sandy runs the National Association of Area Agencies on Aging, and she has a much easier title than I do.
Thank you, Martha. Well, good morning. I am the morning wrap-up speaker, and I know I'm between you and coffee and also the important restroom break. So I'm gonna highlight my points very quickly, but I'm really here to tell you that from the Aging Network perspective, we want to work with you. And we think that we have, and I want to leave you with three thoughts. First is we have a similar mission to the community health centers, which is really looking at promoting the health and the wellness of older adults in this country. So we've got the same mission, and we have a lot of the same clients. Because as Kathy pointed out, through the Older Americans Act, even though that is very broad and really encompasses all older adults, because of the restrictions on funding, we have to very much target those funds to those people who are most in need, which are largely the same folks that you are targeting as well. And because of those 2 points, because we have the same mission and a lot of the same clients, I'm here to say that I think that the time is ripe for a greater partnership between the Aging Network and community health centers. In saying that, when we're looking at our common goal, more and more the Aging Network has realized that we believe, the bridge between the acute care system and home and community-based services. And as you recognize the social determinants in healthcare and recognizing that when you're really focusing in on ensuring the health of the individuals that you're serving, you know that it goes beyond the walls of your clinics. You know that the social determinants of whether people are going to be healthy rely to a large extent on what happens when they get home. And when they get home and when they get back in the community is really the role of area agencies on aging, the Aging Network. And we're talking about the Aging Network. It is the Administration on Aging, the state units on aging that Martha represents. And there are 629 area agencies on aging that touch every community in this country. We also are privileged to represent the 246 Title VI Native American aging programs that serve Indian elders in Indian country as well. But in addition to that group, there's also 20,000 plus service providers that are part of the Aging Network too. And Sue's group, the National Council on Aging, works with a number of those as well. So together, we're a pretty strong and collective force that you all need to tap into. We want you to tap into and partner with us. In looking at our shared mission and our shared client base, as Martha pointed out, when we're looking at the Aging Network, we really are serving people more than just 60 plus. 60 plus in the Older Americans Act was really the gauge point, the milepost for service delivery through Older Americans Act funding. But because the Aging Network has diversified our funding, and as Martha said, 60% of the area agencies on aging are involved in Medicaid home and community-based waiver. Today, 60% of the AAA client base are serving people with disabilities under 60. 37% are serving clients of all ages with chronic diseases. 18% are serving people of all ages based on their financial need. And again, 27% are serving younger veterans, and that's through a partnership through the Administration on Aging and the VA. So in looking at that and looking at the opportunities that are there, Martha highlighted the services and some of the services and support the Aging Network provides. In looking at that, you probably know most people know about Meals on Wheels. And Meals on Wheels are provided through the Older Americans Act, through area agencies on aging, and through contracts with providers. Senior centers, you all know about senior centers, and see those in your community as a gathering place for older adults where you get education, meals, physical activity, all great things. But as Martha pointed out, there are more services and supports that you need to know about and you also need to tap into. And those include adult daycare programs, which provide safe and healthy environments for people, frail older adults, but a lot of people with dementia. Medical transportation, which I know is a major obstacle to getting people to community health centers across the country in urban areas and suburban areas, but primarily in rural areas. Looking at medication management, which was talked about earlier, helping people sort out their medications, because as you know, that's a key and critical issue to someone's health and safety. Being able to connect people to benefits, to let them know what benefits that are out there. And N4A partners with the National Council on Aging through their benefits checkup center, and also looking at making sure that people can connect to medications by counseling through the state health insurance programs and also through the area agencies on aging for Medicare Part D counseling. But another factor, and oftentimes gets overlooked in discussions of health and the aging population, but I think is key and critical. How many of you know the percentage of the population over 60 or 65 in your communities? If not, we can get that information for you. And typically right now it's 12, 13%, but I know in some of the communities across the nation it's already 25 and 30%. But when you're looking at the impact of aging in your communities, when you're looking about the impact of aging in your community health centers, you need to focus in on people 60, 65 plus, but you also need to focus on their caregivers who are walking into your doors every single day. And studies have shown that 1 in 4 adults in this country is a caregiver to another individual. 1 in 4. So even if you think your percentage of older adults is low, depending on your community health center, think about adding in the percentage of caregivers for older adults that are walking through your doors who need support, and we know based on studies and the stress that they're under have health consequences to caregiving. And through the Aging Network, we provide supports to caregivers, help, information, respite care that really do add to their overall quality of life and the quality of life for the people that they serve. But we also do a whole lot on health and wellness too, and this is a growing area. We don't do acute care. That's what you do. But again, we look at ourselves as being the bridge. And as Kathy and Martha pointed out, more and more we're involved in evidence-based health promotion and disease prevention. In fact, 82% of the area agencies on aging do evidence-based health promotion and disease prevention. 82%, and this is based on 2010 statistics from a survey that we've done. And most of that is around chronic disease self-management, which you heard from Administrator Wakefield this morning. 75% of older adults have at least one chronic disease, and 23% of those have 5. So you can see that that's a key and critical issue that we're involved with just like you are. And in looking at the involvement and the growth of the emphasis on prevention and health promotion within the Aging Network, the largest category of professionals that exist at the area agency level are social workers, not surprisingly. But the second largest category are nurses. Because, again, we see our role as being the bridge between your world and our world. And in looking at that and looking at building the bridge, we understand, as you do, again, that when we're looking at the health and wellness of individuals, what happens in the clinic is key and critical, but what happens at home is as well. In looking at that, what we want to do is find more ways to partner with you to be a stronger and better bridge for the clients you serve and the clients that we serve. And in doing that, there are many opportunities. As Kathy pointed out, as we thought more and more about what's in the Affordable Care Act, there really are opportunities for all of us to build and strengthen that bridge between what happens in the acute care world and what happens at home. One of those opportunities is in Section 3026 of the Affordable Care Act, focused on care transitions. And it's that realization that 1 in 5 Medicare beneficiaries was being readmitted to the hospital prematurely, a preventable hospital readmission. And when studies have delved deeper into that, what they found is 40 to 50% of those hospital readmissions were due not to lack of acute care opportunities to connect to acute care. It was because of the inadequacies of home and community-based services once that individual came home. So through Section 3026 of the Affordable Care Act, there were grants, well, not grants, I shouldn't have said that, should I? Program announcement funding opportunities that were done through the Innovation Center that focused in on providing opportunities to test and pilot care transition activities in communities across the country. 27, I believe, of the 30 of those program funding announcements that have been awarded to date have involved directly area agencies on aging, either as the lead or as a critical component of the partnerships that were formed around those care transition pilot opportunities. And there's huge opportunities here for you all and for us to really grow in this arena, as well as what Kathy mentioned about the accountable care organizations and health homes. There's so much there that we can really look at ways to enhance what happens at the community level and what happens in the acute care world. In saying that, partnerships aren't new to the Aging Network. In fact, 76% of area agencies, again, based on 2010 data, said that they partnered with public health, 74% partnered with mental health and behavioral health, and 73%, again, this is 2010 data, reported that they partnered directly with hospitals. So there are a lot of partnership opportunities that have gone on. All of the statistics that I'm giving you are available in this book that you can access through the N4A website, www.n4a.org. 4a.org, which gives you a real overview of area agencies on aging. But most importantly, I'm here to leave you with a message that we want to partner with you. We see you as critical partners at the local level to ensure the health and wellness of the people that we so desperately care about. In saying that, in addition to the Aging Network wanting to partner with you, N4A also would like to be a resource to you, and I'm in conversation with Dr. Webb and is so excited about this cooperative agreement and the opportunities that really provides. If you all don't know how to access your area agency on aging, how many of you do? Some do, that's great, and some don't. N4A, under a cooperative agreement with the Administration on Aging, operates the Elder Care Locator, which is a national call center that you can call and your client base can call to find out about the location of Aging Network services at the community level. The number is 1-800-677-1116, or you can go to the website eldercare.gov. In saying that, that will help you, as well as on the N4A website, locate where your area agency on aging is. I also wanted to tell you that we run the national, in cooperation and in partnership with the National Association of States United for Aging Programs and AARP, through the Administration on Aging, the National Resource Center for Engaging Volunteers in the Aging Network. You all operate with volunteers to be able to help you at the local level, so do we. Again, that's a resource base for you. And recognizing that I've heard from your network, as well as I hear all the time from ours, how big of an obstacle transportation is to getting clients to centers and to get them home and to the services and supports they need. In partnership with Easter Seals, we also operate the National Center on Senior Transportation, which can also be a resource for you as well. And again, recognizing that getting people to benefits is key and critical. We work with the National Council on Aging on benefits checkup, and we also work with SAGE, and I know you'll be hearing from Michael later on, ensuring that we can serve LGBT elders. So together, there are opportunities for all of us to ensure that we can really meet our missions to be able to ensure the health and welfare of all people. And I really commend HRSA, I commend Dr. Webb and her staff for convening this group, because I think through these opportunities of seeing what other systems are doing and how we can work together, collectively we will build a better system for all people as they age. And whether we make that marker 50, 60, 70, or whatever, it doesn't really matter, because what we want to ensure is that no matter what somebody's age is, that they have access to health care and they have access to quality of life. Thank you.
I'm going to turn it now over to Dr. Webb. Thanks so much to this prestigious panel. You've had a lot of really good experience and expert, and I hope you will take their advice and contact each of these organizations. Thank you.
Thank you. And again, once again, a round of applause for our panelists this morning. We really appreciate learning about these partnerships. Well, we're a little bit behind time, but we know it's important for you to have this little break. So we're going to take a break, and we're going to try and make it up in the other plenary sessions. Okay? So in 10 minutes. Okay, thank you.
Good morning. Welcome back from your snack. We're going to get our second panel of experts, our plenary, started. Since we have the administrators talked a little bit too long, we're trying to catch up on time. So just have a couple of housekeeping announcements. First, there are some evaluation forms in your packages, so please fill them out and leave them on the desks and on your tables, and the staff will come around and pick them up from you. In addition, we have exhibitors outside that are eager to show what they have to add to our services and programs, so please take a moment to visit them as well. Without further ado, I just wanted to say I am very, very pleased and very honored to be the moderator for this panel. My name is Rena Ramirez. I am the Chief Medical Officer at Suffolk Health Center in Dover, New Jersey. We are a small health center in northwest New Jersey who has the privilege to be serving our three special populations, the homeless, the residents of public housing, and the farm workers. So this panel is extremely interesting to me. As you have heard, our waiting rooms are aging. The number of elders and seniors are coming to our centers are increasing, and even in the special pops, they also have a presence that we have to contend with. We are faced with isolated elderly who have no insurance, who do not know the English language, who have psychosocial needs, and we need to come up with ways in which to serve their needs and improve their health. So what I will do right now is introduce the panel all at the same time, and they'll come up in that order so that we have time to listen to the wonderful programs and services that they have to share with us. The first presenter is Michael Adams, who's the Executive Director of SAGE, Services and Advocacy for GLBT Elders. It is the oldest and largest organization in the country dedicated to transforming the LGBT aging experience. And what it does is it provides technical assistance, training and services, as well as advocacy. So Michael will go first, followed by Liberty Day, who joined the Health Outreach Partners team in 2008. She is the Senior Project Manager of HOP and includes providing program consultation, training, and information services to local communities and community-based organizations working to improve access to quality health care to vulnerable and underserved populations. Our third speaker is Karen Williams. She is the Public Housing Primary Care Program Director at West End Medical Centers in Atlanta, Georgia, where she oversees the planning, development, and monitoring of primary care satellites and works with programs such as homeless health care, outreach, school health, perinatal programs, and other initiatives for at-risk populations. Finally, we have Brenda Goldstein, who is the Psychosocial Services Director at Lifelong Medical Center, a community health center serving Berkeley, Oakland, and Richmond, California. And she developed Lifelong's supportive housing program into a nationally recognized model of care serving dually diagnosed homeless adults. So let's start with our first speaker.
Okay. Thank you, Rena. It's a pleasure to be here, and thank you to Dr. Webb for inviting me to participate on behalf of SAGE. I'm going to provide my remarks without slides. There are materials in your bag which share the information that I'll be sharing with you, and you also can find additional information at lgbtagingcenter.org. As Rena mentioned, SAGE is the country's oldest and largest nonprofit working on behalf of the country's 2 million LGBT older people. We engage in policy advocacy at the local, state, and national level. We provide training and technical assistance through the National Resource Center on LGBT Aging. And through both SAGE and our affiliate network, we provide community services and serve as a local service provider to LGBT elders in communities all across the country. We are very, very fortunate to work with a large and growing number of local partners of many different kinds of organizations, including the Fenway Community Health Center, which you'll hear from later on today, and Sean Cahill will be presenting a workshop on LGBT services. In 2009, the federal government formally recognized that LGBT older people have unique needs and challenges, as the Administration on Aging announced the creation of the country's first and only National Resource Center on LGBT aging to help spearhead a federal response to LGBT aging issues. And as the Administration on Aging pointed out, in establishing the National Resource Center, prominent among the challenges that LGBT older people face are health disparities and barriers in accessing health care. LGBT older adults, for example, are significantly less likely to access care because of a combination of barriers to service and also fears of mistreatment and discrimination. They face higher rates of depression and substance abuse. They have lower rates of preventive screening, including Pap tests and mammograms and prostate exams. And this is the case even while there is evidence of higher rates of various forms of cancer among lesbians and older gay men and transgender elders. Gay and bisexual older men and transgender older people have a much higher incidence of HIV infection. Transgender older adults face frequent ignorance of their health issues, in some cases refusal of care, and even abuse in healthcare settings. And LGBT elders confront all of these challenges in addition to the health disparities affecting their particular communities of color. So the LGBT older population really is very much intersects with health in very, very, very challenging ways, which is part of the reason why it's so important that we be having this conversation today. The consequences of health disparities are compounded by the fact that LGBT older people generally have very thin support networks, which often lead to severe isolation. They are 4 times less likely to have children who can help them as they age. They are twice as likely to be single and living alone. They are much more likely than other elders to be disconnected from their families of origin. Among other things, this means that LGBT older people often are navigating the healthcare system by themselves, alone. And in a world in which we increasingly recognize the links between health outcomes and community services and local services, unfortunately, LGBT older people face many barriers in accessing those services. There is a widespread lack of culturally competent services that recognize even the existence, never mind the particular needs of LGBT older people. In some instances, there is overt discrimination by service providers and peers. And there is little funding for LGBT-specific service programs. Also, unfortunately, there is still discrimination in our country's safety net for elders. Same-sex couples are denied Social Security survivor and spousal benefits, which cost many LGBT elders tens of thousands of dollars in much-needed retirement income annually. This is especially problematic given that research and data shows that LGBT elders are more likely to be living in poverty than older people in general. And unlike their heterosexual neighbors, same-sex couples in most parts of the country are not protected from spousal impoverishment due to Medicaid spend-down. This means that a same-sex couple may be forced to give up their home and their retirement savings in order to trigger Medicaid coverage for the long-term care needs of one member of the cover, leaving a healthy partner in poverty so that the partner who needs long-term care can get that care. Now, while I've described some of the challenges that LGBT older people face, it's important for you all as health providers to recognize that there are solutions, but there are successful interventions, successful programs that providers can deploy and resources that you can rely on to address these questions. For example, the National Resource Center on LGBT Aging has produced an outstanding best practices guide that offers the strategies and practical tips you need to deliver services in a more culturally competent manner. And in your conference bag is this purple card, which provides information about the best practices guide. and I would encourage each of you to access it online. This guide, called Inclusive Services for LGBT Older Adults, is premised on the idea that knowledge is the key to inclusion. And it's based on surveys of providers all across the country who have learned how to work effectively with LGBT older people and who are sharing their knowledge, their experience for the benefit of everybody else. Every provider can strengthen their services to LGBT elders by adopting suggestions from this best practices guide. In addition, there are many resources available to help you tailor an approach that's particularized, that's particular to your needs as a service provider in your particular community, as you work to become as supportive and inclusive as possible in the provision of care. The National Resource Center on LGBT Aging, and again their website is lgbtagingcenter.org, is a training and technical assistance resource that provides a very broad array of information on how you can adapt your services and improve them. In the National Resource Center's third year, training for health providers will be a priority focus. And we are in the process of developing a special training curriculum for health providers so that you can have more access to information, and this will be available to you in the year ahead. Shifting to the local level, I can't say how exciting it is to see local communities, local providers like yourselves across the country serving as laboratories and incubators as we continue to build and develop new best practices to serve LGBT elders. In my hometown of New York City, for example, the Healthy Aging NYC initiative has developed a new vision of senior centers as hubs for health and wellness prevention and programs. And the SAGE Center, which is the country's first full-fledged LGBT senior center and a centerpiece of the Healthy Aging NYC initiative, will feature a close collaboration between our senior center and our local federally qualified health center, FQHC, focused on things like patient navigation and health education. These are the kinds of ways that we can work together in partnership, and the kinds of partnerships that were discussed earlier today. While there's much that providers can already do to address the unique needs of LGBT older people, it's also important to recognize that there is a strong need for policy reform. And it's important as providers for all of us to support those efforts. For example, in the early stages of implementation of the Affordable Care Act, SAGE worked diligently to ensure that the particular health needs of LGBT older people were addressed in the National Prevention Strategy mandated by the Affordable Care Act. And because we know that more can be accomplished through collaboration and coalition than on our own, we joined forces with 6 other national people of color aging organizations to collectively advocate and ensure that the National Prevention Strategy addresses the needs of all diverse elder communities, of LGBT elders, of elders of color, of elders who are living with disabilities. In addition, to address the terrible hardships that Medicaid imposes on same-sex couples who need long-term care, we're fighting to extend spousal impoverishment protections to those couples. Last spring, the Center for Medicare and Medicaid Services, in a very important step forward, advised states that they are empowered to protect same-sex couples from hardship in long-term care, but they are empowered to protect them from spousal impoverishment. This now requires state action in order to implement this. We're working to convince states to implement the CMS guidelines, and I point out that there's a brochure, again, in your bag that can give you more information about this and tell you how you can get involved in supporting this very, very important advocacy. And to rectify the glaring lack of culturally competent community services for LGBT older people, SAGE is encouraging Congress to designate LGBT elders as an elder population of greatest economic and social need during the reauthorization of the Older Americans Act. An LGBT Inclusive Older Americans Act, combined with the work of the National Resource Center on LGBT Aging, can make a crucial difference on the ground in elder services all across the country, in the same way that you can make a crucial difference on the ground. In closing, I would say that there are a simple three-point agenda that we can all work on together. First is recognition of the health disparities and other unique challenges facing LGBT elders. Second is adoption of best practices to address those needs and do what we can to improve the availability of services. And third is support for policy reform to address the systemic inequities that impose undue hardships on LGBT older people, SAGE's constituents, your patients, your clients. This is the agenda that I encourage all of us to work on together to improve the quality of life for LGBT older people and to improve their health care and their health outcomes. Thank you.
Good morning. Thank you so much for inviting me, having me here, and I'm so glad that everyone was able to make it out today. And I hope that I'm able to provide some information to you that you'll find useful and helpful, especially if you happen to be serving any of the migrant population through your health centers. Just to give you a little bit of background about why I'm here and who I am, I'm the Senior Project Manager for Health Outreach Partners. We are one of 6 national cooperative agreements that are funded by HRSA to provide training and technical assistance to migrant health grantees. And as part of that, what migrant health grantees do is they specifically serve migrant seasonal farm workers, of which there are about 3.5 million in the United States. So what I want to do today is I want to keep it brief because I know that we have 2 other panelists that have very important information to share with you. But what I want to do is just share some of the most common health needs that are faced by migrant seasonal farm worker populations, along with some of the common barriers that are faced. Understanding these are going to be, very important in helping you really address and meet the needs of aging migrant seasonal farm workers. So just to give you a little bit of background about farm workers, when I'm talking about migrant farm workers, I'm really talking about those farm workers who are moving and setting up temporary housing in order to follow the work. And then there's also seasonal farm workers who typically are primarily employed in agriculture but do not actually move to follow work and set up that temporary housing. Something to note of particular importance is that those farm workers who are no longer able to do farm work because of age and disability are still considered migrant and seasonal farm workers according to migrant health grantees. So just to give you a little bit of background about some of those health needs that are going to be important for you to be aware of are specifically related first to the job. Farm work is a very difficult job. It's actually the second most dangerous occupation in the United States. So there's going to be some inherent risks in doing farm work that you'll want to be aware of. And some of those will be specifically related to the type of work that's being done. There's a lot of stooping and climbing, a lot of repetitive motion. So you're going to have a lot of injuries that are related to back injuries or muscle bone injuries, some of which are going to have lifelong consequences. So that'll be important to be aware of. There's also pesticide exposure and skin disorders, some lung disorders, and also, especially for the migratory population whose housing may be very crowded or limited, you'll also see some instances of infectious disease such as tuberculosis. So it's important to be aware of those things when you're working with the migrant seasonal farm worker population. Also, there are some health issues that disproportionately appear in the population that you would want to be aware of. First of all, there's a higher rate of diabetes that occurs. There's also higher rates of asthma, dental problems, and cardiovascular disease. Many of the migrant seasonal farm workers do not have the resources to be able to get preventative care or get care early in the disease process. So sometimes you're going to be seeing people who have more advanced cases and are going to need some additional assistance and help. Something else also to be aware of is that there is a lot of depression for adult farm workers. This could be specifically related to the fact that they're in very difficult work environments and they're usually isolated, and they have economic hardship and a lot of fear about discrimination or seeking services. So all of those are things that you'll want to be mindful of if or when you ever serve migrant seasonal farm worker populations. Some of the common barriers that are faced that I want to note today are specifically related to cultural and linguistic responsiveness and the care that is received. The way this is experienced for a lot of farm workers that are coming in and trying to receive care is that it's very difficult to find providers that understand what their needs are and can communicate that clearly. So what happens is there's general breakdown, and being able to communicate what their health needs are and then understanding the instructions back for what needs to happen. Also, another important barrier is transportation. Of course, all of us are aware of transportation, but the way this really works is that the lack of affordable and dependable, consistent transportation really does present a significant barrier to actually accessing health care in the first place, and then following up for any type of subsequent care is very difficult. Add on top of that any type of mobility issues, personal mobility, and then that even compounds the transportation difficulties. And it extends beyond just getting to and from appointments. It also impacts their ability to get and receive medication or specialty care. Another important barrier is adequate assistance and the cost of receiving that health care. For some of the farm workers that you'll be seeing, they may not have documentation. And for many public programs, that's very important because that would preclude them from being eligible to receive that care. So the cost of care becomes very, very difficult to cope with. So, but for even those who are eligible for the programs, finding information that's clear and understandable is very difficult and can be very confusing. In addition, there's just a general lack of or limitation in dental and vision care services that are available and assistance to help access those services. Another important barrier that you'll want to know about related to migrant populations is the continuity of care. Because you are actually moving and going from place to place, that can make it actually very difficult because you might not have your medical records with you, in which case you might not know what kind of medications you are on or what kind of treatment has been recommended or what kind of tests have already been run. So it can really contribute to either an undertreatment of a situation or a condition or the overtreatment of a situation or condition. So whenever possible, it's really important to help migrant populations understand how to make sure that they get their medical records and transfer those, and that they adequately communicate what their needs are to the next provider that they may be seeing. Just to highlight a few ways how migrant health centers in particular address some of these needs that it might be important for you to recognize is, first of all, they really employ rigorous outreach programs because it's important to locate, especially migratory populations, locate those pockets of individuals and make sure that they get connected to the care and the services that are available in their communities. So they really do employ that rigorous outreach. They also do a lot of enabling services like transportation, interpretation, case management, eligibility assistance to really make sure that they're getting the best services that they can and the access to the greatest assistance that they can. Some other ways is through mobile health, and to make sure that they're providing services, health services, where people live, work, and congregate. So they'll actually take services out through mobile health units, portable health, telemedicine, things like that. And then, of course, they also often try to employ representatives from the communities, the migrant seasonal farm worker communities, through promotora programs or lay health worker programs, to really try to build that trust and connection to the populations, which is going to be very, very important. Trust is, I can't say enough about how important trust is going to be when you're trying to establish those relationships with the population, because word of mouth is huge. And once you're established as a trusted organization, then you can get a lot done with them, and one way to do that is to employ those lay health workers. There's so much more I could say, but I do really want to keep it brief and be mindful of all of the great information that's yet to be shared. So I want to invite anyone to talk to me at any time. I would be happy to talk to you more, especially about how all of these needs and barriers really do affect the aging population. And if I can't answer any of your questions, then there's 5 other organizations just like me that I can connect you with. So if I don't know the answer, I can guarantee you I'll find someone who will. Again, thank you very much, and I'll pass the torch.
Thank you. Good morning, good morning. It's indeed a pleasure to be here with you. I have a slide, but I think I'm going to park it on just one of the slides so that I can kind of talk with you. Those of you, all the familiar faces that I see, know I kind of like to break it with a little joke here. So today will be no exception. I text my son. I have a house full of adolescent and teenagers. So I text him this morning to remind me of a little pun, a little joke that he had this morning. So here goes. What do you call a pony with a cough? A little horse. Thank you. I have others that are better, but nonetheless, they got a chuckle. I'm Karen Williams with West End Medical Centers, and we are a 330E Community Health Center and a 330I Public Housing Primary Care grantee. And I've been around with West End Medical Centers. Actually, I've grown up with West End Medical Centers for 21 years now, where we have been providing primary care on site in public housing communities. And it's been a wonderful treat to see us evolve into many directions. In Atlanta, many of the demographics have changed in the living environment where many of our public housing residents lived, to market rate that are living right next door to public housing, and our senior high-rises have pretty much remained intact. So over the years, we have reached out to provide care to our public housing senior residents. We now have 4 sites that are in public housing communities with 1 mobile unit that we recently acquired, and it's absolutely wonderful. It's been such a gift over this last year, where we're able to take services to our seniors as well as to community public housing residents that have moved out into the various areas where they're no longer centrally located. So in that, it has brought us, you know, I think there's a saying that says necessity is the mother of invention, so that has taken us along many different paths as we've discovered what the needs are. We started out on site in communities and residents where we provided direct care. But that has kind of evolved where community health workers have become our stable force with our seniors, where they're actually going in to take clinical assessments, blood pressure checks, screenings work for cholesterol and glucose levels. And in with that, we're able to then take in our primary care provider into the setting, sometimes often doing home visits for our seniors. We've also recently coupled with behavioral health. We have what we call a survey tool, and we don't really use that word survey tool. We actually have roundtable discussions where we want to hear what the residents have to say about what are the needs that they perceive. Now, of course, we know what all the social determinants are. We know what zip code analysis says, where the highest sense of cardiovascular hypertension and diabetes risk, but we want to hear what are some of the needs that they have. And more often, what the forerunner was, number one, was depression and isolation. So we have now coupled over the last year and a half behavioral health with primary care. We have some other really key partners that we work with to do some really innovative things. We now work with community behavioral health centers, which are much like community health centers, but they target primarily the psychosocial, the mental disorders, and the behavioral issues. So we've coupled that with primary care in our seniors, as well as some of the other populations, special populations that we're working with. So in that, we go to each of the senior high-rises, and we work with about 3 different public housing municipalities in our area, where we go into senior high-rises and actually take in counselors. We take in a nurse practitioner, a community health worker. It's a team approach where we go in and we have specific days where we're actually there to do services. And through those services, we have really come up with some great outcome or evaluation tools to monitor hypertension, diabetes, smoking, obesity, and through that has grown many other opportunities for us to develop programming, such as cooking classes, nutrition, walking clubs. We've even started a gardening club. So all of these things came out of what many of our residents have deemed as important to them. And I'll tell you a little bit of story that kind of hit home. As I mentioned, I have had the distinct pleasure to be with West End for a number of years now. But on a personal level, I think this last few months it kind of really hit home for me. I set out, it was Easter weekend, and that Saturday I had bought this really beautiful Easter lily that I wanted to go share and have some conversation with a senior. So I took my 13-year-old daughter in tow. We went to a senior high-rise. Now, professionally, I'm always in senior high-rises. I professionally have relationships with many of the seniors, know them by name, know their history. But on this particular weekend, I went to just sit down and wanted to have some conversation. So as I mentioned, I had my 13 daughter in tow, this huge plant that I was going to give and going to share and have some really wonderful conversation. And this particular high-rise has 4 floors. So we started out on the 4th floor and went around, and others seemed to be distracted or not really wanting to engage in conversation. Went to the 2nd floor, same thing, not really engaged. Hey, how are you? But not really wanting to sit down and have some robust conversation. 3rd floor is the same. Got to the 4th floor. And still walking around, wanting to engage and have some conversation and see what aspects there may be a need that I could help fulfill. Got all the way around the floor, and it was only a couple of minutes. So then my daughter said, well, what about here? And so we peeped in, said hello, hi, I'm Karen, this is my daughter Naria, how are you today? And they were just so welcoming. That was the last room before we were leaving. And in this room was a 105-year-old mother who was living with her daughter, who was 85, and they were so gracious in having conversation with us. And to that end, we have been friends ever since. I have been by once a week because there was such richness. And believe me, this 105-year-old Miss Sally was very lucid, could carry on conversation, and had no other family members. The daughter had no children, so it was just those two who have bonded all through the years and were living together. So that touched me in a special way personally, not just professionally. I have family members, who are seniors, elderly, but to engage with someone who really wanted the conversation, the fellowship, the opportunity to share what their life had been like. So taking that back in and applying it to professional, the work that I do, Though primary care is important, behavioral health is important, but conversation is so rich to so many of the seniors that we see. And I see why, number one on their list, apart from the cooking classes, apart from the walking clubs, apart from the visits, the tours, the bus tours that they get to go on, is conversation. And I rationalized it within myself that even though I had to go through 4 floors before I actually found someone that we could connect, each one of those that I passed by was looking for someone special to connect with them. I just happened not to be the one for those others that I passed by. So in our effort and in our work, we have now engaged more with our community health workers who are a connection into the community to reach out and bring services. So first there has to be, and though we do 5-year studies, we do planning modules, PDSA, we do all those wonderful things, but I think in this conundrum it comes right back to touching lives when it comes to our seniors. And so when we talk about engaging healthcare or improving the healthcare, both the physical health and the mental health, there's another piece to it, and that's that touch that many of us can bring. And though we don't have the resources in our agency to employ a number of outreach, to go to the 5 different senior high-rises that we work with, we partner with other agencies that do. We partner with some churches, we partner with local community centers. There's a array of opportunities that now we've kind of swung back and tried to re-excite or bring some newness to that which we've already done for a number of years, which is, check the blood pressure, check the glucose level. But in doing so, we have found that just this short period of time that there are some valuable outcomes with having our residents come back to us day after day, or call us, or when our mobile unit is available, that they are out there to come and see the provider. So for a number of opportunities when we work with partners, both the housing authorities, churches that we work with, other civic organizations, we engage them on a bi-monthly opportunity so that we can come up with planning, with many of our seniors being at the head. We oftentimes think that we kind of know what's best. We've been doing this. We've got all the journals and all the information from our professionals as to what will lower it. But we've actually seen, just by socializing with our seniors, that they're more apt to participate and give us information into the own management of their care. We're now introducing some methods where that we give out tools for them to monitor their glucose levels themselves. Oftentimes we think that, they can't really be responsible, but yes, they're very responsible and want to take an interest in managing their care. When I talk about the supportive services, that's a number of ways. That's through staffing that we offer, that's through staffing of the center itself, the high-rise that they're in, and then volunteers, of course. We often use our Urban League for volunteers to come by. Someone mentioned early on Meals on Wheels. Even having conversation with Meals on Wheels to know what's happening with Miss So-and-so in room number 15, or to talk about the responsiveness that you're getting from them, or non-responsiveness that you're getting. It takes communication that's not in silo with all the partners that are involved. When it comes to who's the custodian of care, who's paying their monthly rent, who is the signature on their funding streams that come through. So all of those kind of, and I'm probably preaching to the choir, but sometimes it just hits home after you've have been doing it for a number of years, what's a really better way to do it. And we're anxious to see the outcomes that we have. We've partnered with Emory University in cardiovascular through NIMH to actually do a study on the outcomes of bridging the gap between primary care and behavioral health. And especially we're targeting one of the area populations is our seniors to see what kind of impact that we're able to do through this model with all the indicators. When we talk about obesity, obesity, with losing weight, when we talk about smoking, decreasing the smoking. All of these indicators that will have a better and healthier outcome for not only our seniors, but those who are engaged in behavioral health stressors. We look to have a more clear bridge between those two as we reach our seniors. And as I mentioned, I could go on with other slides, but I'd like to close with this, that when we talk about, I have listed here power brokers. Those are often the persons who have lived in these communities for a number of years, who actually know from day in and day out. They're the ones who are going to check on their neighbors next door. They're the real power brokers, and we're to follow their lead if we allow them to lead. Thank you.
I'm breaking with tradition, and I will be using some slides. And while they're coming up, I'm going to ask a question. How many of you are over the age of 50? Raise your hand. Proudly, we're in an aging conference, yes. And I'm going to assume that most of you woke up with a roof over your head, in a comfortable bed, with a bathroom where you could use the toilet, where you had your medicines stored. What I want to talk to you about today is about folks who don't have those luxuries, our aging homeless population. My name is Brenda Goldstein. I'm with Lifelong Medical Care. We're an FQHC which was founded by the Gray Panthers about 35 years ago. We serve about 40,000 patients in the Berkeley, Oakland, and Richmond, California area. And we have spent the last 35 years developing models of care to serve our seniors and disabled, homeless, and very complex patients. We have a very robust supportive housing program and 2 clinics that are funded to work in public housing, and all of our sites have integrated primary care and behavioral health. So we have a very, very deep focus on providing comprehensive wraparound services that serve the whole person. That was not, you were not supposed to see it. I was going to test you all to find out who knew what the life expectancy is in the United States. Pretend you didn't see the slide. Somebody yell it out. 78. It's about 78. Japan. Anybody know Japan? About 83, 84. How about Mongolia? I'd be surprised if anybody knew what Mongolia was. 100. Mongolia is around 67. Ethiopia is 53. But if you're homeless in the United States, your life expectancy is 46. If you take nothing home but that, just remember that. Who are the elderly homeless? Homeless people age prematurely. Many individuals who experience homelessness will not reach what we consider to be old age. And we typically, because of that, define elderly homeless as age 50 or older. I know in our supportive housing sites, we have many people who die mostly in their 40s, some in their 30s. And an increasing percentage of homeless are getting older. From the 1990s, when there's been an 11% increase, so that now 30% of the homeless are 50 or older. And homelessness is going to double between 2010 and 2050. So this is a growing population, and one in which we need to be very aware of what the issues are. We have providers, although not enough, who know how to serve the elderly. We have providers who know how to serve the homeless. But combining the needs of both the homeless and the elderly into a package of services is a real specialty, and one we're really just learning about now. And, the last 2 years, we've seen a lot of new homeless folks with the recession and people losing their housing. And I'm speaking primarily about the chronically homeless and the folks who've been living on the streets for a long time, but we're also talking about the homeless who are newly homeless and experience extreme stress as the bottom has fallen out of their lives. And they are extremely, extremely vulnerable. This is just a graphic to really demonstrate the increase in homelessness in several different cities across the United States. What was interesting for me in doing a little bit of research for this project was how difficult it is to find statistics on the homeless and the elderly. Most of the statistics I found were coming out of Europe. not out of the United States. Made me wonder, how much attention are we really paying to this issue? How much do we know? How much do we still need to learn? And what should we be doing to really learn more so that we can meet the needs of this very vulnerable population? The elderly homeless have high rates of substance use and mental health disorders, often untreated for years, if not decades. They have high rates of involvement in the criminal justice system, often with limited employment or educational histories. And their men, African Americans, and Vietnam-era veterans are significantly overrepresented in this community. That doesn't mean you're not going to see a white female who has a PhD. We have plenty of folks who are highly educated living in our supportive housing sites, especially in a university town like Berkeley. And access issues are a huge, huge factor. There are 9 seniors waiting for every occupied unit of affordable elderly housing. Just getting into housing is a big issue. And another point that I really want to drive home that you'll see on several slides is that if you're thinking about health care, housing is a health issue. Housing is a health issue. Many of our homeless folks and seniors lack insurance and income, even though they may not be eligible for SSDI because they haven't worked or have significant work histories. Most folks are eligible for SSI, but it's so difficult to get on. And one of the things we're really anxious about is for the Affordable Care Act to move forward so that folks can at least get Medicaid, because it will no longer be linked to SSI. Just by virtue of being poor, you'll be able to get Medicaid. Right now, we have to do a lot of work just to get people onto a benefit that will link them to Medicaid. Folks have a very complex physical, cognitive, mental health, and substance use issues, which require really specialized providers and providers who want to serve this population. This is not an easy population to serve. There are high rates of emergency department and inpatient utilization because the elderly homeless are not getting access into primary care. And there's a tremendous need for coordinated services. One of the special projects that we work with is with a community-based agency that provides wraparound services with a mental health model for homeless seniors. And we provide actually the psychiatry and the medical case management. And we went in thinking we were going to be providing primary care on site. It turned out that most of the seniors were connected to a primary care provider. These are folks who were 60 and older, and they had somebody they had a relationship in the community with who was their primary care provider, but their care was so uncoordinated and scattered, and they really didn't understand much about their medications. They didn't understand about the specialty care. There was no communication among their providers, and there was very little being done in the way of health education. Turned out what we needed to really do was medical case management in collaboration with social workers and mental health workers. And when I talk about case managers for this population, I often in the healthcare system, we think about nurse case management and medical case management, which is extremely valuable. But this population really needs a combination of medical and psychosocial case management. You can't have one without the other. Health issues. For me, the number one health issue is a lack of housing. You cannot begin to address folks' health issues until they are stably housed. Our seniors have our homeless seniors have age-adjusted mortality rates 3 to 4 times that of people living in housing. And chronic disease, they're 3.5 times more likely to have a chronic disease. So the percent of homeless adults in their 50s with chronic disease is similar to that of the general population 65 and older. It's often very difficult with a homeless individual to really identify what's going on. We have folks who come in and, maybe they come in and when they come for their appointment, they've been drinking, they've just used crack the night before, they're high, they're maybe not quite coherent. It's very difficult to tease apart whether they have a mental health issue, a psychiatric issue, or a cognitive issue. And you need to have providers who have the skills to be able to tease those issues apart. You also need to develop long-term relationships so that you can really get to know the person's behavior and understand the behavior in the context of their life. and begin to understand what behaviors you're actually seeing and recognize them for what they're for. That takes skill, that takes training. In our supportive housing sites, we have amazing case managers who do wonderful work with the supportive housing clients, but they're not necessarily well trained in understanding cognitive decline. Being able to really recognize when someone is starting to show symptoms of dementia. They often will just attribute that to substance use. Oh, Mr. So-and-so, he's been drinking again. That must be because of his drinking. Maybe not. Maybe there really is something else going on. Seniors have tremendous vulnerability on streets and in shelters. They're victims of violence, of scams. They're very scared to go into shelters, would prefer to often to stay under the streets, on the streets or under freeway passes. And what's also interesting is there was a recent paper out that looked at geriatric syndromes in the general population versus the homeless population. And homeless adults experience higher rates of geriatric syndromes compared to the general population. Now, the good news is that these are symptoms and conditions that are often amenable to intervention, but it means that you need to recognize them. So if somebody who's homeless and is 45 or 50 years old walks into a provider's office, they need to be assessing for functional impairment. They need to be assessing for depression, for auditory impairment, and providing intervention. They need to recognize that this person, even though they may only be 50, even though they may only be 45, by virtue of the fact that they've been homeless for 10 years, needs to be assessed for things that you would normally assess an older person for. Lots of environmental issues faced by people who are either on the streets or recently housed. Because even when it's housed, we know that it's difficult for elders to manage disabilities. When you're homeless, it's almost impossible. If you have medications that need to be refrigerated and you don't have a home, you can't refrigerate them. If you need access to a toilet and you're on the streets, you don't have access to a toilet, let alone with bars to help you actually manage yourself. You're at high risk of falls. You're on the streets, dodging traffic. And you certainly can't afford or necessarily maintain assistive devices. I can't tell you how many people we've had with problems with their wheelchairs who can't get the assistance they need to either fix their wheelchair or get a new wheelchair. Wheelchairs don't last that long when you're out on the streets. And yet Medicaid only covers a new battery or a replacement wheelchair every 5 years, I think it is. It's also very difficult to get personal assistance. You really can't get in-home supportive services if you don't have a home. There is no such thing as under-the-bridge supportive services. Many homeless individuals are very socially isolated. They've burned all of their relationships. They often don't have any connection with their family, with their children, and may have alienated any friends who might be able to help. And they face very, very distinct social and emotional issues. When you're homeless or you've been homeless for a long time and just recently housed, planning for end of life can be quite difficult. We have several of our clients who really have worried, who's going to take care of my body when I die? What will happen to me? What's going to happen with my family? We're working with a few people right now who desperately want to reconnect with their children, but they feel tremendous guilt about the fact that they abandoned their children when they were younger, that they were alcoholic and felt like they couldn't take care of their kids and disappeared, and now are wanting to reconnect but don't know how to do that, both emotionally or actually practically. They also are having difficulty trying to find meaningful activity to fill their lives, and it's important to be able to connect folks up with other seniors in social activities, trying to get folks, if they're recently housed, out of their housing and over to senior centers where they can fill their days with people and activities. And of course, being socially isolated makes it extremely difficult to deal with crises. We have a lot of folks who die in their rooms, and hopefully somebody notices. Hopefully there are enough people in their lives who notice that they're not around and somebody goes to check on them. So what are effective strategies? First and foremost, prevention of homelessness for seniors and rapid rehousing when a senior does become homeless, and getting people who are on the streets and are elderly off the streets as quickly as possible. Screening homeless adults for geriatric syndromes at a young age. Very integrated and highly coordinated care. using multidisciplinary teams and very intensive case management. Trying to keep people in supportive housing and developing supportive housing that has a focus on the needs of seniors. And trying to keep people in their housing as long as possible before they go into an assisted living situation. Understanding the difference between those two, but also identifying assisted living situations in the community that can address the need of homeless individuals and people who are duly diagnosed with mental health and substance use disorders, and have the staff who can actually relate to those folks and have the patience to really provide services. And also developing medical respite in your community so that people are not discharged from hospitals back out onto the streets, but have a place to go where they can stay during the day, where they can get help with their medications and heal until they're ready to get back on their feet. Policy issues, eliminating barriers to qualifying for benefits, developing supportive housing targeted to homeless elders, really integrating the conversation about housing into health care, and the fact that housing should be a health care benefit, and that it's cheaper to house somebody in a supportive, subsidized housing than it is to put them into a skilled nursing facility. Supportive housing, if you count the subsidy for housing and case management, typically costs between $15,000 and $20,000 a year. It's a lot less than skilled nursing. Discharge policies, as I mentioned, that ensure elders don't go back into homelessness, and payments to medical providers that support very intensive medical and psychosocial services that are needed, the wraparound services that are needed for elderly homeless. And someone mentioned at the beginning of the day the impact of managed care in our current environment. And I know that for us in California, pretty much all of the seniors and people with disabilities who are on Medicaid are now being moved into managed care. And yet we have not really moved with managed care forward to develop models of both payment and service provision and quality assurance that really focuses on serving this very high-risk population. And we need to be having those conversations at all levels, locally, at the state level, and federally, to assure that managed care plans do develop these models and work with their local organizations who know how to serve this population. And finally, this is a client who we just housed last week. He had been living on the streets for more than 10 years. He's a veteran, and this is what it's all about. He got the keys to his apartment. The first thing he did was close the front door and let out a huge kind of war whoop hooray that he was in his own place. We can really change people's lives when we provide the right kind of services, and we have to remember that this is what it's all about. Thank you very much.
I'd like to thank our panelists who gave great presentations, really shared the struggles and the challenges that our special populations and aging face, and gave us some solutions and perhaps some ideas that we can go back and implement at our own health centers. Thank you very much.
Hi, I'm Kelly Horton, and I work at the National Council on Aging in our Center for Healthy Aging. And I'm very excited to introduce this next panel. And I know we're running behind time, so you do have their bios, so I'll just say a little bit. Danielle Nelson is here with the Administration on Aging. And then we have Ken Stone, who is with the American Academy of HIV Medicine, and then Dr. Daniel Merrick from the Office of Rural Health Policy at HRSA. And they're each going to take a few minutes and tell us about the importance of aging and HIV in this emerging issue.
Am I on? Can you hear me? Okay. Ken Stone is a lovely name, but my name is Ken South. Little confusion there and the stuff. I'm with the American Academy of HIV Medicine. We're a medical association of HIV providers from across the United States, and it's been around for 10 years. If there's 3 bumper stickers I would like you to memorize before you leave. And the first one, please repeat after me. Seniors have sex. Now, this may not be news to you, but it is really news to an awful lot of people. We're in incredible denial about the sexuality of seniors. The second one is Age is not a condom. Age is not a condom. A lot of people think that I'm one of the, on avocation, I'm the president of Primetimers here in D.C., a club for older gay men and our admirers. And a lot of our members seem to think that if they just have sex with other old guys, they won't get AIDS because AIDS is a young person's disease. The fact is, AIDS is not a young person's disease anymore. And the most recent statistics show that by 2015, which is precious little time, by 2015, 50% of all people with HIV infection will be over 50. That is an incredible statistic. There are about 1.2 million people in the country today living with HIV infection and HIV disease. In the next 3 years, half of those will be over 50. That has incredible implications for treatment, for prevention, for services. And frankly, the system, while there's been lots of talk and conferences, and we're glad to see more concentration on HIV and aging, the system is not ready for it. There are two groups of people that are in the HIV aging population, two cohorts. The first cohort, thanks to the wonderful job of treatment and to the wonderful new drugs that are around. I started out in AIDS in 1984, where people were diagnosed with pneumocystis pneumonia on Friday and were dead on Monday. We have come a long way since that. And so there are people now, majority of people with AIDS are going to die of diseases of old age. They're not going to die of AIDS. They're going to have AIDS, and they have AIDS, and many of them have for 30 years. That's the first cohort of people who are over 50 with AIDS. The second cohort is, unfortunately, the newly infected. 17% nationwide of people over 50 are new infections. And you would think that by now everybody has heard HIV messages coming out their ears, and they would know how not to get infected. Knowledge does not equal prevention. We know how many people, I won't ask you to raise your hands, how many people in this room still smoke, for instance. Knowledge, or don't put on seatbelts, knowledge is not prevention. Behavioral change is prevention. We thought at the Academy there's one way that we can be helpful since in this whole aging and HIV area, since we are an association of providers, that we would look at the issues around treatment and people over 50, people with AIDS over 50. There are no until now, treatment recommendations for clinicians to deal with people who are infected over 50. So we put together a blue ribbon panel of 13 nationally known experts, half of which were geriatricians, half of which were HIV specialists. They worked together diligently for 2 years and put together the first treatment recommendations for people over 50. There are copies of the summary here you're happy to take. And we also have it on our website. You can read it on the website. And we are instituting a blog on our website so that clinicians and patients can enter in their own experience about what it is to be treated with HIV over 50. We haven't got a moment more time to go into that. It's a very detailed workshop. It's its own conference. But we're glad to see that OAR and other national organizations are now looking at making guidelines, which take a lot more time than recommendations, and look forward to the continued treatment of people over 50 with HIV. Thank you.
I have just a few slides. I want to share with you the AOA HIV and Aging Toolkit. And I am going to be very quick because as a pregnant woman, I want to eat lunch just like everyone else here. So we will make this quick. AOA, we, as Kathy Greenlee said earlier, we're really about prevention. And so one of the issues that came up around the 30th anniversary of the first diagnosed cases of AIDS in the U.S., we did a webinar for the Aging Services Network. And we were just blown away by the large numbers of registrants and attendees. And then afterward, a lot of our area agencies on aging contacted us. Great, we know this is an issue specifically in our community. What resources can you point us to? And so we realized then, we need to kind of step up our game. And so the first step in that direction is this toolkit. And really, there's no need for me to go into these statistics because it's been covered by a lot of people today. And then, like I said, AOA, this is kind of our snapshot of what we've been doing around HIV and AIDS. And then the last bullet is this toolkit that we just released earlier this year. To go to it and access it, if you go to AOA.gov, you'll see this nifty little button here on the right-hand side. If you click that, it'll take you right to the toolkit. And then this is a quick video that's 5 minutes, but I'm not going to show it because, again, we're thinking about time. But this video is an educational video, in my opinion, very well done. It's great to show, not specifically just at HIV education events, but any sort of a health fair, community, a community program. It's a great way to, a lot of the feedback we've received is that there's really no need to have just a HIV education for seniors because you're not going to get a big audience, but really to have it in any sort of disease prevention, health promotion, educational event. It's a great way to show and get awareness. There we go. This is our fact sheet. It's great to print off, have in doctor's offices, any of your centers. It just really goes around the issue that, like others have said, you know, sex doesn't stop at 50, neither does the risk for AIDS, and this fact sheet gets into that. We also have a customizable PowerPoint template. It's nice because it has all the facts in it for you, so you don't have to do the research yourself. Everybody's busy. You can pick and choose slides, also input your information. If you're ever doing a PowerPoint out in the community and you want to raise awareness about HIV, AIDS, in older adults. This is our toolkit poster series, and so each poster specifically talks about the risk and getting more information and how to get that information. It also has at the bottom resources to AIDS.gov and actagainstaids.org and how to get tested. So really these poster series are to put up in places of interest to seniors, whether it's the library, the grocery store, doctor's offices, your health centers, just to raise awareness that this is an issue, kind of like the bumper sticker. It's a way to put a face in to HIV other than younger adults. And then this is just an overview of the toolkit. It talks about each of the resources, how to use them, what the best example is to, you know, where to put these posters up, the fact sheets, how to use them and whatnot. Here are some resources, and then this website, this will be up on the North American Management website if you would like to get any of this information, or I invite you to contact me if you have any questions.
And I'm Dan Merrick. I'm with the Federal Office of Rural Health Policy, and also in the interest of time, I will cut my remarks short. But I'm delighted to be here to give you a little sense for some of our rural activities that at least can complement some of the great work you folks are doing related to elders and aging needs. So I just have a few prepared remarks I'm going to go through, and again, I'll cut this down by about half in the interest of time. The Office of Rural Health Policy coordinates activities related to rural health care within the United States Department of Health and Human Services. Part of the Health Resources and Services Administration, or HP, has department-wide responsibility for analyzing the possible effects of health policy on 62 million residents of rural communities. We provide the internal federal voice for rural health policy to HHS and to Congress. ORHP advises the Secretary on health issues within rural communities, including the effects of Medicare and Medicaid regulations on rural citizens' access to care, the viability of rural hospitals, and the availability of physicians and other health professionals for rural America. Because many of the policy levers at the federal side are related to the Medicare program, review and analysis of prospective changes to Medicare comprise much of ORHP's policy work. So again, we advise CMS on how rural elders would be affected by prospective Medicare and other health policy changes. Healthcare delivery is challenging in rural locations where patients tend to be older and have less health insurance than their urban counterparts. Not all rural communities have availability of long-term care services such as skilled nursing facilities, retirement housing, Meals on Wheels, home health services, hospice care, and many of the other services that you have been hearing about this morning. Home health services in rural and frontier areas are also variable. High-end therapy availability, adequately trained workforce, and transportation and travel issues are a few of the challenges. Care transition is also very challenging in rural areas. For instance, an elder falls in the home, is transferred to a city medical facility for care, and then returns home. So who provides and coordinates the support needed for continued rehab once the patient returns to the rural area? I'm going to skip over some of the general federal policy issues related to rural elders and such. So in the last couple of minutes, I can focus specifically on some grants through the Office of Rural Health Policy that might help for some of the rural elder challenges that you have. So again, the Office of Rural Health Policy programs, we can complement the work of the National Center for Health and the Aging in helping to address the healthcare needs of rural seniors. ORHP defines health broadly to help address the wide-ranging and community-specific healthcare needs across rural America. Many of our grants provide 3 years of seed money support with the ultimate goal of developing regional and local sustainability to carry on. In fiscal year 2010, the President introduced the Improving Rural Healthcare Initiative. And in support of this initiative, we administer 17 grant programs funded through 10 legislative authorities designed to build healthcare capacity at both the state and local levels. So here are a couple of specific examples of Office of Rural Health Policy grants that have the potential to benefit rural elders. And in our Hospital State Division, we support the Medicare Rural Hospital Flexibility Grants, the FLEX grants, which focus on critical access hospitals, which are rural hospitals with no more than 25 beds, and they have some other specific qualifications statutorily as well, but the main focus is they are less than 25 beds in rural settings. So the FLEX grants provide support for 3 main initiatives: quality improvement for the critical access hospitals, operational and financial improvement for these facilities, and help to develop collaborative regional and local delivery systems. And there's approximately $41 million available annually through this program. We also have community-based programs such as our network planning grants. And these grants can be used to start cooperative ventures in rural areas that could certainly help rural elder needs. This is usually an annual competition, and 12 new awards were just announced earlier this month in April. And there's up to $85,000 per grantee for one-year awards available. And again, these are to start the dialogue of forming networks. And you can do many things with these networks, such as community care-based transitions and things that could help the elderly. And again, these are usual annual competitions, so something to keep in mind. We also have network development grants, and often our one-year planning grants turn into 3-year network development grants to help create, again, rural infrastructure for the needs of many in rural areas, including elders. And usually about 20 awards are made here with an average award of about $180,000 per year for 3 years. Now, there just was a competition in fiscal year 2011, so it'll be another couple of years before another round of network development grants will be funded. We also have outreach grants, which help to increase access to care in rural areas. And again, these often relate to the formation of networks to help coordinate care better in rural settings. And these grants, in fact, there's a competition that's going on right now in fiscal year 2012, and we're going to make 80 awards up to $150,000 per year for 3 years. We also have small healthcare provider quality improvement grants, and these focus on chronic care related to diabetes, cardiovascular disease, and obesity. And obviously, these are all areas that impact elders, including in rural areas, and we support we are having a competition that will be late summer this year to support 30 to 40 new awards related to this endeavor. We also have an office for the advancement of telehealth, and obviously telehealth technology has expanded greatly and is crucially important in rural settings. And again, we have a number of grants that focus on cost-effective issues such as telehome care for elders and all other telehealth network grants that can be helpful as well. And for those of you who have more of a policy interest, the Office of Rural Health Policy also provides staff support for the National Advisory Committee on Rural Health and Human Services. And this committee provides the external voice related to rural or to federal rural health policy, and a number of their reports address rural elders, such as a policy brief that just came out in December of 2011 related to the Affordable Care Act provisions and how they affect the rural elderly. And also, a component of the 2010 report to the Secretary discusses home and community-based care for rural seniors. Other recent reports have touched on family caregiver support of the rural elderly, serving the rural elderly, and all these reports are available online. And in summary, again, I'd be happy to facilitate contacts with you through our Office of Rural Health Policy if you want any more specific information about some of these programs and how they might support rural elders. And again, my email address is dmarek, D-M-A-R-E-C-K, @hrsa.gov. And I'll be happy to visit with you and provide other contacts if you so desire. And again, thank you very much for the opportunity to be here, and have a good lunch.
Well, we're not done yet.
Oh, okay.
I'll be the one person who does it.
Oh, okay.
And delays lunch.
Back to our moderator.
So I just want to thank you all so much. And as I was listening to you, and you were sharing the resources, I'm just curious how many people had seen those resources for HIV and aging for the first time? So quite a few people. You didn't get a chance to show the video. I have seen the video. It is an excellent video. I think we watched it together, Ken and myself. And it extends all sorts of audiences, I think. And on YouTube, I asked you the question, only about 300 people have watched it. Oh, sorry.
I don't want to turn that up. Here,
Is this on?
you can have mine.
Mine's on.
Oh.
It's fine? The mic is fine. Oh, okay, all right. So I went on YouTube after we did a webinar a few weeks ago to look at the video again, and only about 300 people have watched the video on YouTube. I think maybe some more have watched it on the AOA website. But we know there's several thousand community centers. So I would just really encourage all of you to watch that video. What I did was liked it on my Facebook, liked it on my professional Facebook, my LinkedIn, so that it gets the message out. Because it really is something that's very important, and the statistics, I think, coming up in the next 20 years, the amount of people over 50 with HIV and AIDS is just really scary. So just getting the message out as much as possible. And then I was thinking about, back to our conversation a few weeks ago, somebody had asked the question from a healthcare center, how do we use these resources and reach people in a rural area? And just that's sort of all connected for me. So I'm wondering if you guys can talk about that just a little bit. How do we reach people in a rural area around HIV and AIDS? And how do we make this a conversation that healthcare centers will feel comfortable talking about? Oh, okay.
Well, in terms of how to...
I apologize. No one from the House is here, so I think if for the House to hear, I think you're going to have to use this one.
Okay. So maybe you can repeat my question, your answer.
The question is related to how can HIV resources be translated into rural areas, and I don't know if Dr. Wakefield this morning, the HRSA administrator, mentioned, but she has a strong interest in how to collaborate with Agency on Aging programs writ large and with HRSA programs writ large, and that includes in rural areas. And so there's been a lot of work that we've been doing internally on the HRSA level, working with the Administration on Aging to try to coordinate better to make sure that our HRSA grantees in general across all of our areas, including rural America, as well as the Administration on Aging programs, so that they know what's out there. And there's actually there's going to be another workforce meeting with representatives from both HRSA as well as the Administration on Aging that's going to meet at the Administration on Aging offices on May 10th, I believe, Friday, May 10th. And which will go the next step to try to put a document together, a resource document together. So ideally, everything that's available between the programs will eventually, trickle down to the various partners, so that everyone will know what is out there. On the rural side, we support the state offices of rural health, and again our flex coordinators, which support critical access hospitals and such. So we have email listservs that we give updates, and our community-based division gives updates on the community-based programs on a regular basis, usually every other week. And so whatever resource documents come together related to HRSA and Administration on Aging resources, we will definitely provide that through our listservs to our rural
constituents, so they'll be aware of what else is out there and how they can work together better. So again, that's a definite interest for Dr. Wakefield, and I think that probably before the end of the calendar year, there'll be some document that we'll be able to disseminate out.
The Academy's one piece of this is that we've recognized that there are people treating people with AIDS in rural areas or in lower concentration areas. We're the only national organization that does credentialing of HIV specialists, and we have a sub-program within that called the Low Volume Provider. So providers who are seeing less than 20 people with AIDS in a year are able to apply to us for a full credentialing program and take the exam, but they will be linked up with a high volume provider as a mentor so that they can glean more professional information from them. So that's one of our. The other thing is, frankly, the internet is the great, leveler. You don't have to drive from one place to another anymore, and so many resources are available on the internet that I think helps a great deal with rural communities.
And one quick thing I wanted to say is I don't know if anyone here has seen the PSA around safe sex in seniors that started in the state of Florida. If you go to safesex4, the number, seniors.org, the PSA is right there on their homepage, and it's a 30-second PSA for the state of Florida. And it's definitely eye-catching, brings a little bit of humor to a difficult topic that I think most people have difficulty talking about. And hopefully we'll be seeing more of that come out because it's mainstream, it reaches everybody from rural to urban communities, and it's something that if you watch TV, you might come across.
Thank you for lunch, so if people have questions, you can feel free to ask them during lunch. Thank you.